got a good blood pressure in your cuff blood pressure. And then further down the line, a right IJ is placed and you have SATs of 78%. What does this represent and what monitoring you're likely to use? Think over it, and we will come to this case again at the end of this presentation, what can be done to optimize the child and how we use monitoring in this context. Now, why do we monitor? I think you all will agree it's monitoring is fundamental to safe anesthetics as well as ICU practice. And again, the important thing is it helps us in decision-making and also institute timely interventions. It's important to realize that monitoring is not therapy, and monitoring alone doesn't change surgical or anesthetic outcomes. And it's very important to realize that clinicians need to know how to interpret the data accurately. Coming to congenital heart disease, some of the considerations are the physiology will determine your targets. For example, your saturations target would be different in cyanotic congenital heart disease. So you need to know what is the baseline target or the baseline saturations of the patient. Similarly, also, there are different physiologies, whether you're dealing with a restrictive physiology or an obstructive physiology or a single ventricle physiology, and that will determine what you're trying to achieve and what numbers are you seeing on the monitors. The other things to consider is the anatomic considerations. For example, if you have arch anomalies or you have a child who has had a coarctation of artery repair with a subclavian flap, and you kind of put your arterial monitoring on the side, then you may not get on the side of the subclavian flap repaired, and that may not be representative of your true arterial blood pressure. So it's always important to remember what anatomical abnormality actually the child has or the patient has. And the other thing is important is if there are any residual shunts or stenosis or any other residual lesions, which may determine the physiological parameters. Please let me know if I'm too fast. I can slow it down, and if I'm visible.
Still going perfect.
Is that okay?
Yeah, good.
Okay, great. So I think this is a very important paper. I would recommend if there are trainees in this group to kindly have a look. It's an old paper, but basically, and I think we all know about oxygen delivery, oxygen consumption, but it does tell about some of the caveats when we are measuring these parameters. And again, as we come to monitoring, you probably all know that none of the monitors actually are ideal, which gives us the exact physiological or the exact physiological state of the patient. That is why we need to use a combination of monitors to determine and institute the most appropriate therapy. Now, coming to what is the purpose of all this monitoring? We have all the lines, invasive lines, non-invasive monitoring. But basically, I think from a hemodynamic perspective, what everyone is trying to achieve is ensure adequate oxygen delivery, as we know that hypoxia is bad and for organs and tissues and is associated with increased peri-operative or ICU mortality and morbidity. Now, if we see that, as you know, the equation for when you're trying to deliver oxygen, you need a good pump, you need a good cardiac output, and also it's determined by the arterial oxygen content, which in turn is determined by your hemoglobin and SATs, and your cardiac output is determined by how much volume is ejected from the heart with each heartbeat, and also the rate. Neonates are slightly different in that they cannot increase their stroke volume, but basically they're heart rate dependent to increase their cardiac output. But I think new studies are emerging which are showing that sometimes there can be a degree of stroke volume variability. And coming to your blood pressure, the blood pressure is determined by how much blood is ejected or your cardiac output and your systemic vascular resistance. And all of this, as you know, you need a perfusion pressure to keep your organs perfused, and which is determined by your difference between your mean arterial pressure and the central venous pressure or the venous pressure difference. So as you know, there are a few things which actually are quite visible, and these are the things which you can, you don't have a hemoglobin but some of these are continuous, like you have a SATs monitoring, which is continuous. You have a heart rate, which you can get continuously. You can get mean arterial blood pressure continuously if you're using an invasive arterial monitoring. And if you have a CVP monitor, then that's it. But that's not always the case. Now coming to, we'll go through each in detail one by one. And so if I may just start with the pulse ox, I'll try not to spend too much time on pulse ox because I think you all are used to using pulse ox. But essentially it measures the saturation of hemoglobin from pulsatile blood flow, and is based on the principle of Beer-Lambert law, which basically shows that the intensity of light decreases with increased concentration of solutes, and also the intensity of light traveling decreases as the distance increases. So basically, you are looking at the chromatic properties, and it measures the difference in absorption of oxyhemoglobin and deoxyhemoglobin. The important thing to remember, because it's pulsatile blood flow and there's a lot of artifact, you have only 2%, which actually determines what your arterial saturation is. So never look at just at your saturation. Please look at the pleth before you make an interpretation of your sats. The other things to consider, if your patient, because this is kind of validated when the algorithm is validated against normal population. And as you know, it's not possible to kind of reduce your saturations in the normal when they were kind of developing these machines. I think the pulse ox came around in the 70s. It's not possible to induce hypoxia, and it's not safe to induce hypoxia. So that is why it is not calibrated less than 70%. So when someone says, oh, the child has sats of 30, I don't think that is of any value. Yes, it is low, but we don't know the exact number. Similarly, if there is extraneous light source that can contaminate, or you may not get the true reading. And if there is non-pulsatile blood flow, especially in shock states, it's difficult. So I think you would need a PO2 in those cases. And as we know that we want normoxia, a lot of literature is coming out about the side effects of hyperoxia. So the pulse ox doesn't tell you if you have hyperoxia. So these are some of the caveats. Now, coming to pulse ox, in terms of relation to cardiac conditions, different cardiac conditions will have different saturation goals. It depends on the degree of mixing. It depends on the physiology, whether you're doing with a cyanotic or a non-cyanotic heart disease. And also it depends on the QPQS. For example, if you have a child or a patient with critical coarctation or a baby with critical coarctation, that would have normal saturations. In contrast, if you have a child with single ventricle, then it's perfectly reasonable to have saturations of 75 to 85. And in that case, actually targeting a higher saturation would be harmful because you will compromise your systemic cardiac output. So it's important to kind of base your sats or your target based on the lesion that you have in hand. The next thing that we can monitor easily and is commonly monitored is blood pressure. And as you all know, there is both invasive and non-invasive blood pressure monitoring. And multiple studies have shown that hypotension is either intraoperative or in the post-operative period is associated with increased mortality and morbidity. So let's focus on non-invasive monitoring first. We are talking about, this is intermittent. You can't get a continuous. So that is what the problem is. And also in pediatrics, you will have different cuff sizes. And so that needs to be taken into account. It's not a one size fits all. And that is why you can get so many discrepancies in blood pressure when you're actually doing non-invasive blood pressure monitoring in children. Now, in terms of the principles of oscillometric method, basically blood flow causes variation in the arterial wall, which can be detected and basically it is then changed into electrical signals by the pressure transducers, which is in the cuff. And it is detected by pneumatically coupled sensors. And as you can see, so as you decrease your cuff, you can see some oscillations, which is picked up by the pressure sensors in the cuff, and that determines your blood pressure. So the maximum oscillation determines your mean arterial blood pressure, and systolic and diastolic pressures are derived using proprietary algorithms. Now, with regards to non-invasive, it is a clinical reference method. It is the most common blood pressure monitoring method that you use. It's easy, it's non-invasive, but the problem is it's intermittent. So if you want continuous blood pressure or the beat-to-beat variability, you're not going to get it with the non-invasive. But in children, especially like if you have a child with ductal lesions or coarctation, we sometimes do full limb blood pressure measurements. So it may be useful in those circumstances because you're not going to put in arterial lines in 4 limbs. But the important thing is the proper cuff size and positioning is important. And also the performance is actually worse than it is generally assumed. So if you are dealing with a child or a patient who is hemodynamically unstable, I think invasive blood pressure is always better. Now, coming to invasive monitoring, you put in an arterial catheter with a non-compliant tubing, which is connected to a transducer, and the transducer converts the physical signal into electrical signals. The important thing in this is the level of the phlebotactic axis and basically the referencing. The phlebotactic axis, which is actually the level of the right atrium, it's very close to the level of the aortic root, and this is used as a reference point. So if you're moving your transducer up and down, which commonly happens when, for example, you're moving a patient from bed to another bed, or even if you're moving your pumps, etc., and you have to move your transducer, then you may get an erroneously low or high blood pressure. So just be mindful when patient movements happen, and also it's important to calibrate frequently. Now, coming to invasive, so the invasive blood pressure, it's kind of considered the cornerstone of hemodynamic monitoring. I think the problem is you need, for an optimal quality of blood, you need a good trace, firstly, and the quality of the trace is very important because the performance characteristics are described by the natural frequency of the measurement system. By frequency, I mean that if, for example, so how do we do is a fast flush test, essentially. Basically, what you do is to inject some saline and look at the oscillations in the system. And the other thing you look at is the damping coefficient, which describes the decay of the oscillation waveform. And damping is influenced by the length and diameter. That is why we stress on the importance of a non-compliant tubing. And the problem is, in children, optimally damped lines are only seen in around half of the critically ill children. That is why whether you can rely on it, and that is why you need frequent calibration, frequent zeroing. And also this flush test, though it's described in adult by Gardner in 1981, it's not, I haven't seen my nurses doing it routinely in our ITU practice. And most of the times you see, like, we say that a normal trace has got a dichrotic notch, and you see the normal waveform where after you do this test, you get a square waveform and probably 1.5 oscillations. So that is described as a normal waveform. In an overdamped trace, what you see is you don't see the dichrotic notch, but maybe you can get one, but it's usually less than 1 oscillations. And in an underdamped trace, you get a lot of oscillations after you have done your fast flush test. Now in children, I think we don't routinely do it. I don't know the practice. I don't know if you do it in theaters, but I haven't seen that as a common practice in ITU, but I think we should. And especially in children above 10 kilos, it's possible. It's not impossible to do it, but it's not a routine and common practice. Now, coming to the advantages, obviously, as I already alluded to, it gives you beat-to-beat variability. It's helpful in sampling. And also nowadays you can give a continuous cardiac output monitoring. The important things are to check the dynamic response, as we have already alluded to make sure your transducer is leveled. And then children have small arteries. These are some of the complications. This is a child who we had in our unit actually with an arterial line. And then as you can see, the tips of the fingers can sometimes fall off if you're not cognizant. So please be very mindful. If you have a white limb, or if you get when you flush the line, if there is trucking along the line, please check your distal perfusion, how it is, and be mindful about arterial pressures. They can be nasty and limbs can fall off. And especially in neonates, where you put in a big catheter in a small vessel, and also with multiple punctures, the incidence increases. The other complications are obviously you be mindful when you're flushing your arterial lines, because there can be air in there and you can introduce it into the systemic circulation. There can be retroperitoneal hematoma, especially with high femoral lines and fistula formation. Now, comparing NIBP and invasive blood pressure monitoring, obviously, I think in adults, you'll find lots and lots of studies. In children, there are a few studies. It's not like we don't have literature. But again, there is no consistency in the studies. So this was a study, I think, done in 2014 by Ricky et al., where this is looking at the comparison between invasive and non-invasive blood pressure in cardiac kits and cardiac surgery. They had 51 patients with a total of 546 observations. As you can see, it was less than half where they were the IABP and the NIBP were within their reference range of 5 millimeters of mercury. So in others, there was a lot of, which means that in 60% of the cases, there is no agreement between your invasive and your non-invasive blood pressure. The other thing what they noticed is that in children, there was low incidence of underdamping artifacts. And I think that is to do with the fact that children don't have the stiffening of the arteries that you see and that you see in older patients. And what they saw was that the NIBP, the systolic blood pressures were higher, and whereas for the mean and the diastolics were lower with NIBP when they were compared with invasive arterial monitoring. So I think if there is a doubt whether your tracing is, and whether you're damping or under damping artifacts, where you're concerned, I think it is important that we compare both the variables, and that is what I normally do in clinical practice. But again, you should not be, I think our decisions should not be based on just an isolated blood pressure measurement. I think we should take the whole context into picture, and it's important to integrate all the variables that we have in front of us. So as I said, BP should not be the sole therapeutic target in unstable patients. So this is a recommendation which has come up in 2020 from the European Society of Pediatric and Neonatal Intensive Care. So some of the indications: if you have shock, which is unresponsive to vasoactive medications; if you have a child or an adult with intracranial hypertension or a neurosurgical where you're trying to target a CPP or cerebral perfusion pressure; during major surgery where you're anticipating major fluid shifts; and when you're managing hypertensive emergencies. Those are the indications of essentially having IABP. And the other thing which is not mentioned in the guideline, we are an ECMO center, and we have a lot of patients on ECMO. So we do use IABP on ECMO. And similarly, if you're a transplant center on VATS, you would normally see that patients would have invasive arterial monitoring. Then coming to CVP, I think, again, I won't go into the more details because I think we're limited by time, but basically what you're measuring is your filling pressure of the right ventricle and the right atrial pressure. The caveat being, you are measuring pressure, like, you're trying to assess the volume, but you're using pressure as a surrogate of volume. And as you know, when you look at your compliance, so there is an inverse relation between pressure and compliance. And the other thing is that CVP catheter can be challenging. In children, you need to sedate them. In adults, you can do it under local anesthetics, but in children, I think it can be difficult. So it's not without its own risk. So to be accurate and useful, so you're making a few assumptions that you have a normal RV compliance. There is no pulmonary vascular disease. There is no valvular heart disease and no LV failure. But if you're actually talking of children or adults with heart disease, I don't think this holds true because there will usually be one or the other type of pathology. That is why when you're interpreting your CVP, trend monitoring is important rather than a single value. It is useful, I think in our setup, it is useful when we do have CVP monitoring in all our postoperative cardiac patients. It can help us when you're having rhythm issues, or even when you're having tamponade, when you can see a sudden jump in your central venous pressure, or even in children with restrictive physiology where they need high filling pressures. The main thing is to remember it's a poor indicator of volume status. There is also a poor correlation with stroke index in PIMENT, suggesting that CVP is not useful in predicting fluid responsiveness in critically ill children. And this is also reflected in the recommendation for ASNIC that you should not base your fluid loading based on CVP or a low CVP. Isolated CVP is not of value, is of no value. So trend monitoring is important. And also, if you're suspecting evolving right heart failure, or for example, if you see a sudden elevation in CVP upon fluid administration, then probably there is some degree of cardiac dysfunction going on. Next is, this is commonly used, mixed venous oxygen saturation. And I think it's important to understand where we measure it because I think by definition, you are trying to measure the end result of oxygen consumption and delivery. So it should be in the most distal venous circulation prior to oxygenation. I have left the normal values there. So normally you have 65 to 75, and if you're measuring it, so normally mixed venous would be measured in your pulmonary artery and you need a pulmonary artery catheter. But we use superior vena cava saturations as a surrogate marker, and it usually tends to follow the mixed venous to some extent. Now, you have a child with a left to right shunt. Where do you measure your mixed venous? That is the question, because by definition, we said prior to oxygenation. So in this context, probably it is relevant that you will measure it in your SVC, because if you measure it in your PAs, you won't get, because you will have oxygenated blood coming to your right atrium from the left atrium. So that would not be a true reflection. Similarly, if you have a ventricular septal defect, you have shunting going on in your ventricular level. So it is reasonable to measure your mixed venous in your right atrium, for example. So I think it is important to understand what you're doing and what you're measuring. And again, I would not go through all the details. You all know it. What is low mixed venous when you see low mixed venous? But basically, if you have reduced oxygen delivery due to any cause, you can have low mixed venous saturations. And similarly, in high output states, you can also have high mixed venous where there is mitochondrial failure, where tissues are not consuming oxygen. And then there have been several trials using early goal-directed therapy, mostly adult trials, reverse in the 80s, where they showed that early goal-directed therapy influences outcome in mortality. But the recent trials of process and ERAs, they don't show kind of mortality benefit. But if you compare both the eras, actually our survival in sepsis has gone up. And that is because I think people are getting better in managing sepsis and in recognizing all these patients. I think that is what inference I can draw from these studies. Next comes NIRS monitoring. It is kind of like a window to the brain. It's very useful, non-invasive, portable, continuous, and it's not operator dependent. And the beauty is that it's kind of gives you both cerebral and cardiac monitoring. And normally there is kind of 10% difference between right and left cerebral NIRS is acceptable. Similarly, 10% between cerebral and somatic NIRS is acceptable. And it does show good correlation with your lactate values, and your area under the curve, as you can see, is 80% in one of the studies. It measures the non-pulsatile absorption as opposed to your arterial saturations, but it is based on certain assumptions. It assumes that the ratio of arterial and venous blood is 70:30, but the reality is more complex. That is not the case. So there was a study by Ito et al. Where they subjected patients to hypocapnia and hypercapnia, and this was a PET scan where they did cerebral volume assessment, and they found that there was a discrepancy, and actually it is not a 70:30 ratio, which is kind of the assumption. And again, with cardiac surgery, with flow reversal, how does it change? I think that is something we need to look at. This we already talked about. So some of the recommendations are basically mean cerebral NIRS, you target it around 70%. In cyanotic heart disease, 46 to 57% is acceptable. And again, as with all monitoring, trending can give you good, better information than isolated values. But it is not recommended for routine use of NIRS during non-cardiac surgery. That's one of the ASHNIC. And I think, Michael, you'll be talking on it again probably to some extent, but it's not in cardiac surgery. It is used commonly. We do use it in our unit, but it's not for non-cardiac surgery. And in ICU, when do I use it? We do use NIRS monitoring on ECMO. We do use NIRS monitoring on our neonatal post-cardiac surgery patients. And I think in the ECMO setting, especially if you have VA ECMO and you're managing respiratory ECMO, once the heart function recovers, and I'll show it in the next section, I think here. So initially, when the heart is not pumping, you are measuring your NIRS. If you're not measuring, this is okay. There's global, you have red in your brain, which is good. As your heart function recovers, and depending on the position of your arterial cannula, you may see that actually you are getting desaturated blood represented by blue in the picture. And if you have if you're just monitoring your arterial blood pressure, you may not see. So if you put a NIRS monitoring, you may be able to see a discrepancy between your right and left cerebral hemispheres in this case, especially when cardiac function is improving. The other thing is when we are cannulating for ECMO, especially femoral cannulation, and sometimes when the reperfusion cannula is not put in, you might see, if you put you kind of see that your limb is getting blue. If you put in so that is where we sometimes use it in our setting. It may detect the need for a reperfusion cannula. I mean, we always normally we normally don't do that many femoral cannulation in children, but if it's a peripheral cannulation, and especially if you have a child who's an adolescent size, then that may give you some idea. And also in compartment syndrome, but there's again studies, they need validation. So cardiac output and stroke volume measurements. Does anyone know who this person is? So this is Adolf Fick, German, who first described your Fick's principle. And then you had Swans and Guns in the 70s to 90s. But this paper, I think, changed our practice to a great extent, that they show that 26% increase in mortality with the use of PACs. Hence, there is more move towards non-invasive monitoring. Now, in terms of, so this is the adult consensus on circulatory shock from ESICM, which said that you would measure cardiac output and stroke volume to evaluate basically response to fluid and inotropes who are not responding to therapy, meaning if you have had volume expansion and vasoactive drugs and then there is no response, then cardiac output monitoring is indicated. However, as I said, PACs are associated with increased invasive and also increased complications. So echo is the first preferred modality of choice. It's a level 2 evidence. And in complex patients where you're not winning, then in that case, you may consider using pulmonary artery catheterization or transpulmonary. Again, this is level 2 recommendation. So this was in 2014. This was followed by pediatric guidelines. I think this was in 2020. So again, it says cardiac ultrasound or echo for hemodynamic evaluation of children with instability. We don't measure cardiac output with artery catheters unless it is in cardiac cath lab or when you're doing kind of a diagnostic cath. It's not a routine practice. If you have refractory shock and you need cardiac output, then you can use, but there was a very weak agreement in terms of which modality to use. And also there was no agreement among people that we need cardiac output monitoring. I think the problem in children is, again, the validation. And the last, I think this is probably, we are coming to an end, the lactate, initially thought to be a waste product of anaerobic metabolism. And as time has gone on, we have realized how important it is. It's a major source of energy and metabolic fuel. And there is an association between persistent hyperlactatemia and mortality and morbidity. The benefit it is, I think the disadvantages are, it's non-continuous, it's invasive, and it's a latent detector. Like, you'll have hypoxia, but your lactate, there is a lag between hypoxia and your lactate rise, and it doesn't guide us about disease or treatment. That is the problem. And as you can see, this is the DO2 and the VO2 relation. I think I don't need to go over it, but basically VO2 is normally independent of DO2 over a wide range of values. But when you reach your critical value around this intersection, then DO2 will fall respective. So I think it's important. And then at that point, you'll also see a rise in your lactate. And again, in terms of microcirculation wise, we don't have studies that define the normal values of microcirculation in children outside the neonatal period, so we don't use it. So coming to our case now, I think this is kind of, in a sense, the hemodynamic monitoring tools that we use in day-to-day practice. I didn't touch upon the diagnostic cath or the parameters that you use in cath lab, because you can do PACs, etc. in cath lab, but we don't routinely do it in a normal day-to-day practice or in the OR. So coming to this case, is a child in, what do you make of this child? Sick, non-sick? Are you going to anesthetize him, not anesthetize him? If you have any inputs. Anyways, so I think what, I don't know if it's, so as I said, this is a single ventricle circulation. You have a right IG, so normally with a Norwood, or it's a this is a banded or a palliated single, no, it's not palliated, but you're kind of, your circulation is balanced here, where you have a PA band and you have a ductal stent, so you're trying to balance your QP and QS. You place an right IG line, and probably you also have an atrial septectomy. Your saturation is 78%. Their normal saturations would be around 75 to 85%. So what this means is that you have a higher saturation, or your higher mixed venous or superior vena cava saturation. That means your oxygen consumption, there is a problem here. Either it's a delivery issue or it's a consumption issue. So this child is sick. So please use your monitoring carefully. So because sometimes it's very easy to gloss over these things and not realize, but this child needs attention and probably needs to be moved to your ITU. So the take-home messages, the choice of hemodynamic monitoring should be individualized. Clinicians should know how to interpret the data. Monitoring is an adjunct. It doesn't replace your clinical examination. So please don't forget to measure, to touch and feel your patient, to look at your charts, to look at your capillary refill time, to look at your temperature difference, to look at your urine output, because those gives you vital clues in addition to the monitoring. Monitoring is just an adjunct, so that everything should be taken in context. And I think the future non-invasive monitoring is, we are now looking at like non-invasive continuous blood pressure measurements, non-invasive SCO2 measurements, and also non-invasive cardiac output measurement using the PLETH. So I think in future, we will have integrated systems which kind of give us feedback about how we can use these tools to betterment of our patients, and how you can use these tools to kind of institute therapy early. And the other thing I always say that, resources are finite, but surprises never stops. And your best monitors are your bedside nurses. They will tell you alert you about deterioration before anything actually picks up. So please listen to them. don't dismiss your nursing team or people who are at the bedside continuously looking after the child, or the mother who's with the child 24/7. They are the best monitors. Thank you.
Dr. Sachin sir, Dr. Jaswant sir.
Thank you, Pompa, for that talk. It's a very good talk. There's already a couple of questions that have been asked.
Yeah.
We're going to answer the questions at the end of the session.
Yeah.
That's okay.
I think we will take the questions at the end of the session.
Yeah. So I think moving on to the next lecture.
Yeah.
Next speaker, I think it's Dr. Padalwar, Snigdha Padalwar. So, and I think you're going to talk about remote location anesthesia.
Just introduce Dr. Snigdha, please.
Yes, ma'am. But before that, we would like to felicitate our speaker, Dr. Pompa, with an e-memento.
Okay.
I stop share actually.
Stop sharing. Ma'am, please accept our e-memento as a token of our appreciation.
Thank you so much.
You have to share your screen, Priyanka.
Trying that, ma'am. I'll just slide it. Yeah. Okay. So now, moving ahead to our next speaker, which will be on remote location anesthesia for cardiac remote location anesthesia for cardiac patients, safety ensured, by our very own Dr. Snigdha Padalwar, who I can proudly say is a JNMC alumnus, I being one myself. I wholeheartedly welcome you, ma'am.
Thank you. Thank you very much.
Video. Start.
Because I can see my colleagues logging in different time zones. First of all, I would like to thank the organizing committee for giving me this opportunity to share my experience and views on this very interesting topic, NORA for cardiac patients. So,
Increase the volume, please. Priyanka, please increase the volume. And start again.
Priyanka, can you hear us? We could not hear a voice.
Are you able to hear the presentation?
Dr. Priyanka, you have to go back, increase the volume and restart. We could not hear the voice.
Okay, ma'am. Should we restart the presentation?
Yeah, you have to.
Okay, ma'am.
good morning, good afternoon, and good evening, everyone. Because I can see logged in from different time zones. First of all, I would like to thank the organizing committee for giving me this opportunity to share my experience and views on this very interesting topic, NORA for cardiac patients. So, I chose to talk upon this topic because I realized that it comprises almost 50% of my routine everyday practice, and I believe in near future it's going to be an exploding part of our portfolio and will comprise a larger share of our anesthetic practice. NORA actually means anesthesia for painful and uncomfortable procedures in an unfamiliar and unconventional setting. If you take a look at the historical aspects, there's a very interesting fact that the three anesthetists who were credited for discovering anesthesia, WTG Morton, Horace Wells, and C.W. Long, provided their first anesthetics in a non-operating room setting in a dental suite or a home. So I would like to build my talk across this framework highlighted on this slide. I would first discuss the challenges, review a literature, discuss how to be risk averse and mitigate complications, and I would cite some case-based examples from my everyday routine practice with a good foundation of basics of cardiac disease, risk assessment. So we all are witnessing an emerging trend where we can see there's a rapidly evolving and improved medical and surgical science with advent of ECMO, mechanical circulatory support devices, advanced percutaneous interventions, a very well established palliative surgical pathway for single ventricle patients supported by better diagnostic tools and expertise of the proceduralist. And what is this leading to? It is leading to increased life expectancy and significant rise in aging population who come with the significant and increasing comorbidity. Also, some of the patients who are too sick to undergo major operation are posted for minimal interventions and diagnostics, and we as an anesthesiologist end up providing anesthesia to them. So what is the general trend and statistics reflecting at? It shows that in next decade, the number of cases will be more than half of all the anesthetics delivered. And it is going to lead to increase in case volume, less provider experience, higher acuity patients. And these will all be the causes of potential complications, potential adverse events. And how can we prevent it? By having a uniform standardization of care as we have in our OR settings. A sneak peek into literature reflected a very interesting trend, which was cited by the authors of this article, which is printed in British Journal of Anesthesia in 2021. The authors reviewed the articles from 94 to March 2021, and they highlighted that there was a trend in the morbidity and mortality, death claim and complications, which were more seen in the earlier years, mostly attributed to failure of oxygenation and ventilation, seen in older, frail pediatric patients because of the lack of post-op care, time pressures, older technology, lack of monitoring and standardization. However, after the intervention of the ASA and the Anesthesia Patient Safety Foundation, which recommended to have similar standard of monitoring and anesthesia care in remote location anesthesia as we do for operating room scenarios. So the recent articles published by Korean authors showed a greater parity between the NORA and the OR cases, and this was attributed to better awareness and preparation for NORA. Now coming to the cardiac patients, why do we consider these patients special? So look at the uniqueness of the cardiac patients. They have a rapid compensation needed to life-threatening situations. And also these patients come from various and extensive spectrum of cardiac involvement, and each disease have a very peculiar and a specific pathophysiology. They are on gamut of cardiac medicines, which can have drug-drug interactions with our anesthetic agents associated with complex syndromes, and they are exposed to multiple drugs and multiple anesthesia. And that's why they become tolerant to anesthetics, and sometimes dosing them for anesthesia is difficult. So what are the desired skill sets for the providers who's looking after and providing anesthesia to these patients? The provider should be able to judge and select his patient appropriately, whether his own or her skill sets they match the complexity of the patient. He should be skilled in resuscitation, should have a good knowledge base of cardiac medicines like vasopressors, dilators, and protein, and the next should be expert in understanding the heart interactions, hemodynamic monitoring, blood pressure, pulse relationship, should have a basic knowledge of ECMO like focus, assess, trans therapy, echocardiography, long ultrasound assisted lines, should be skilled in managing T1 and sedation, TCI, and should be used to work in different locations and do crisis resource management in case of contingencies and eventualities. So the high risk factors of the adverse events which are known to occur in these locations are attributed to 4 P's, and they are based on provider, patient, place, and procedure. So providing anesthesia in remote location anesthesia itself is stressful for any anesthesiologist because of off-site and familiar locations. Sometimes these locations are in the basement of the hospital, far away from the main operating room theaters, and that's why the anesthetic feels unsupported from his colleagues. Also, these lists are very high volume, fast-paced, with rapid turnover and limited time to optimize and evaluate his patients, and that's why it gives a poor sense of control of patient and the procedure. We are expected to work in different sectors like cardiology, gastroenterology, dental suites, diagnostic imaging, A&E departments, ICUs, and each of this site has a peculiar layout, machines, equipments, different kind of procedures, and we need to be familiar with all of them before we decide to provide and take anesthesia and do anesthesia for cardiac patients in this environment. So this is a typical scenario in any of the cancer settings, which can be very scary. This is a 3-kilo baby on cath table undergoing a very critical procedure, PDA stenting. But if you can see how he's surrounded by the multi-plane and the biplane C-arms, anesthesia, machines, monitors, equipments, all of them. So this definitely.
Hello, hello, Dr. Anjali, Dr. Priyanka. Voice break खूप होतोय. Dr. Snigdha, if can go ahead beyond this slide, तो बरं होईल.
Okay, shall I do live from here?
अब यहाँ से live करेंगे तो अच्छा रहेगा, because what is happening there is a lot of breaking. So nice presentation is going on. We don't want taking this intermittent breaks.
Okay, so
Can you go ahead with live?
Yeah. We'll stop sharing. We'll not. We have to stop the video and then go share your screen.
Yeah, I'll do that. I'll share my screen. Okay.
Oh, that will be better, I think. Yeah.
Thank you.
Thank you very much.
Can you see my screen?
Yeah. All well.
Yes, please go ahead.
Okay. So because we have time constraints, so I'll start from here.
Yeah.
So
Yeah.
So coming to the special considerations in cardiac patients. So how are these cardiac patients unique? Because they have a rapidly changing pathophysiology, which is very precariously balanced and easily gets tipped off, even on a trivial incident. They are prone for acute clinical decompensation, and which can lead to life-threatening situations. Most of these patients, they have extensive spectrum of cardiac involvement, and they come from each group, and each group has a peculiar pathophysiology, and we as anesthesiologists are supposed to know the pathophysiology of that specific group. These patients are on gamut of cardiac medicines, which are very complex medicines. They can have drug-drug interaction with our anesthetic agents. Most of the time, these patients are associated with some or the other complex syndromes and critical illness. They are also exposed to anesthesia multiple times because of undergoing multiple interventions and operations in the past, and hence they develop tolerance to anesthetic agents. And that's why sometimes it really becomes difficult to do the dosing for them to get the appropriate effect. So what are the skill sets we are looking at for a person who is looking after the cardiac patients in the remote location anesthesia? So we should be able to do a proper patient selection, matching the personal skills to the complexity of the patient. If suppose patient is ASA grade 1 and 2, he has a repaired heart disease, which is adequately controlled and there is no active cardiac condition going on, then this and that patient has to undergo a low risk operation, then this patient can also be looked after by a person who's not trained in cardiac anesthesia. Of course, it also depends on the experience and the confidence of the provider. So the provider should be skilled in resuscitation. He should have a very good knowledge base of use of cardiac medications like vasopressors, dilators, inotropes, and antiarrhythmic agents. He should be expert in understanding heart-lung interactions, hemodynamic monitoring, ventilation perfusion relationship, should have some basic knowledge in echo, should be able to do focused assessed transthoracic echocardiography, lung ultrasound, and ultrasound assisted lines, should be skilled in managing TIVA, max sedation, TCI, and should be trained to work in different locations and do the crisis resource management. So the risk factors which can lead to the adverse events are based on 4 Ps. It depends on the provider, patient, place, and the procedure. So for any anesthesiologist, providing anesthesia to a cardiac patient in remote location is quite stressful and harrowing because mostly it is off-site in unfamiliar locations, far away from the main operating departments. And in some facilities, it is also in the basement of the hospital. So it gives a sense of insecurity to the anesthesiologist because it's difficult to get support from his fellow colleagues. Also, most of the time, these lists are run by a single anesthesiologist, and these lists are high volume, fast paced, and with a rapid turnover of the patients. And the anesthesiologist, he doesn't get enough time to evaluate and optimize the patients. So all of this put together gives a poor sense of control to the anesthesiologist and adds to his stress. We are also meant to work in different locations like cardiology, gastroenterology, dental suites, diagnostic imaging places, A&E department, ENT, and ICUs. Each of this place has a different layout, different equipments, machines, different kind of procedures, and the performer. So if we are going to give anesthesia to patients in all these different locations, we are supposed to know the details of all these places, and we all should be familiar with these places before we go ahead. So this is a very we all are familiar with this picture, which is from the cath lab, and there is a 3-kilo baby on table who is undergoing a very critical procedure, which is PDA stenting. And this is a usual scenario. Look at this: the baby is surrounded by multi-plane C-arms, anesthesia machine, monitors, infusion pumps. And it is very difficult for the anesthesiologist to pitch in and to lead and to intervene if at all something goes wrong and in any uneventualities. And coming to the patient, we all know it's a high risk. These patients are all high risk and they are known to have comorbidities. They have complex physical, psychological, and clinical status. So coming to the procedure related factors, most of the time what happens, these procedures are ambulatory, and the expectation from the anesthesiologist is to provide a deep, intense anesthesia, and yet the patient should get up immediately after the procedure and should be fit to go home. So this again is a very challenging situation. Some procedures are very complex, for example, hybrid procedures, and then also making out the duration is sometimes very unpredictable. Like you plan anesthesia for a longer duration procedure and suddenly the procedure really says that the procedure is over. And so that's a planning anesthesia becomes very difficult in these situations. Assessment of blood loss again is a different challenge, especially in cath lab with small children. Some of the procedures carry very high risk for life-threatening events, and everything is compounded by patient position and limited access to the patient. How do I approach to these scenarios? So I try to follow this mnemonic. Every anesthesiologist really loves morning coffee. So the first thing I see is whether it's an elective, emergency, or rescue. So many a times it happens that there is a patient undergoing some kind of procedure in a cath lab, and I'm called as a rescue anesthesiologist because the patient had some kind of complication like hypoxia, tamponade, or maybe a cardiac arrest. And then as an anesthesiologist, you should be able to quickly assess the situation and pitch in and offer the help. So I try to categorize whether it's elective, emergency, or rescue. And then the next thing I see, if there is any active ongoing cardiac condition, for example, a patient with myocardial angina coming for primary angioplasty, or if there is a swelling top in ICU and I've been called to intubate and do the invasive monitoring lines for that patient. Then the other thing I look at is the risk of the procedure and intervention. If it is a low risk procedure, there is no active ongoing cardiac condition, it is an elective case, then I usually tend to go ahead with the case. Looking at the metabolic equivalence in an adult gives me a fair idea of the cardiopulmonary reserve, and we can plan our anesthetics based on that reserve. Having a cardiology opinion or offering for more investigation, just see if it is going to change any further management. The last but not the least is having a baseline vitals and especially saturation in congenital patients, because this gives a fair idea like where the patient likes to sit in terms of numbers. And then also see if patient is optimized adequately to undergo anesthesia as well as the procedure. Doing a pre-anesthetic assessment gives you a fair idea of the cardiac condition of the patient, whether he's stable, unstable, or he's precariously balanced. Look into the past therapeutic interventions, whether it is whatever the group of disease it is, whether it is congenital or acquired. Are there any comorbidities which I need to take into account while I plan my anesthetics? Most of the times these patients are anxious, combative, and they would be helped if we go and talk to them and they feel reassured. Confirm a proper NBM status, review the specific investigations like CT, echo, cath data, have blood and blood products if the procedure demands, and if it is an emergency, do the same steps, but under time constraints and because it is time critical. So after evaluating the patient, I try to follow this chart. In my everyday practice, I try to categorize patient either in adult or congenital, emergency, elective, or rescue. Look if there is any active cardiac condition. Look at the ventricular functions. Most of the time, adult patient you can categorize in coronary, valvular, cardiomyopathies, pulmonary hypertension, arrhythmias. Look at the comorbidities. And if it is a congenital heart patient, then categorize, we can put him in two categories, single ventricle patients or a biventricular patient. If he's a single ventricle patient, has he undergone palliation and what stage of palliation he is in? And if it is a biventricular patient, just see if it is repaired or unrepaired. If he's repaired, then does he have any residual lesions yet, like shunts or outflow tract obstructions? And then look at the comorbidities. Once you know the cardiac condition of the patient, then look at the risk level of the procedure. If it is a low risk level, for example, dental, TOE, CT, MRI, then it is okay to proceed. And if it is a high risk level, for example, like airway cases, radiofrequency ablations, PPVI and TAVI, then it's better that the procedure is done by a trained cardiac anesthesiologist. Like I said before, even these procedures carry a very high risk. So always have a details of this procedure, like what is the type of the procedure, duration, access, position, any interventional challenges, what is the expected blood loss, and also what is expected from us. Do we need to maintain the spontaneous breathing of the patient or no? And what is the contingency plan? And always discuss the contingency plan with the team. If I'm new to the position, if I'm new to that place, I always make a point that I pay a visit, brief the team members, allocate role to each team member, and I prefer to take my anesthesia technician with me because it makes life and everything easier and simpler for you. Then always discuss your contingency plan with the members. Have an MDT if there is any high risk factors, and never forget to look at the SOAP MI. I always follow this. Look at the suction, oxygen, airway devices like self-inflating bag, pharmacy, monitors, and IV access. So once you have done all that, plan the layout, assemble all the necessary equipments as per the requirement of the procedure, and have adequate patient warming devices, because most of these places are cold, and especially in neonates and small children, they tend to become hypothermic. I always carry a checklist and I prepare my patients as per the checklist. Coming to the anesthetic management, have a proper valid consent, and then formulate your anesthetic plan based on the clear hemodynamic goals. Decide if you want to have an invasive or non-invasive monitoring parameters. And the hemodynamic goals, I generally decide on rate, rhythm, preload, afterload, and contractility. We all remember that age-old chart we've been learning from our training days, which gives us specific values for each specific cardiac lesions. So plan your anesthetics based on 3 phases of anesthesia, like drugs for induction, maintenance, and recovery. And last but not the least is the most important, post-operative recovery. Always have a team allocated, a place allocated, and level of monitoring what you want. I plan my anesthetic drugs based on these factors: age, weight, and cardiac status of the patient, nature, duration, and place, and what is expected out of the anesthesia. Whether the patient just needs reassurance, anxiolysis, or he needs immobility, analgesia, maintaining of spontaneous breathing, or apnea, or permutation combination of either of these. So based on all this, we have plenty of choice to do. It all depends on the personal comfort and the patient. We can choose from conscious sedation to monitored anesthesia care to GA-LMA, GA intubation. All of this can be supported by TIVA and local anesthetic. So most of the cardiac most of these cardiac patients, as I said before, are highly anxious, combative. Some of them have history of panic attacks because of the past unpleasant experience. So pre-medication would definitely help them. In our unit, we have a practice of giving pre-medication, mostly to the pediatric age group, and we have 2 ways of doing it: pharmacological and non-pharmacological. For pharmacological methods, we can use oral or nasal midazolam, chloral hydrate, diazepam, and generally tend to avoid in airway abnormalities. To combat anxiety in little older children, we familiarize them with the various places. For example, cath lab or MRI, we take them around and show them the places where they are going to be. And sometimes it really takes care of their anxiety. In babies and neonates, we can breastfeed them, wrap them up, and keep them warm. And it's sometimes easier to do procedures like CT and MRI. So coming to the monitoring, as per the ASA guideline and recommendations, the level of monitoring needs to be same as we do in the operating room. In some specific places like MRI and cath labs, just take care that the equipments and the everything, whatever you use, are ferromagnetic safe, they are MRI safe, and we should have adequate long monitoring lines, cables, circuits, etc. If you decide to have an invasive monitoring line, it should be decided taking into consideration the risk and benefit ratio, but it entirely depends on the anesthesiologist who's conducting it. I find TIVA a very attractive option in these scenarios because it doesn't cause emergent delirium, it mitigates PUNV, there is less risk of laryngospasm and stridor, it doesn't rely on any airway adjunct, and it's easy to maintain the breathing, easy to titrate according to the clinical needs of the patient, and induction can be slow and controlled and cardiostable. So, and also it is very easy to deliver TIVA these days because of the availability of improved infusion pump designs, having pediatric drug delivery software, having open loop and closed loop systems, and we can use the drugs with synergistic actions because this will help in reducing the dose of each drug and provide cardiac stability to the patient. The preferred drugs are propofol, dexmedetomidine, remifentanil, and fentanyl, and the best combinations which we have felt in our clinical experiences: propofol with remifentanil and propofol with dexmedetomidine. These are the doses which we use, but because of the time constraints, I would like to not go through these slides and coming straight to the examples. This example is from my everyday routine practice. This was a 12-year-old boy, 60 kilo, trisomy 21, status post 3 sternotomies and AV canal repair, recurrence of subaortic membrane, laryngomalacia, tracheostomy in situ, behavioral disorder, highly combative, non-cooperative with difficult IV access. Now, if you read this, any anesthesiologist will feel a little flabbergasted that there are too many things going around this patient. And then how do you organize everything for this patient? So it's not all about cardiac anesthesia. When you try to do remote location anesthesia, you need to take into consideration a lot of other factors. So what I generally do, I try to organize my mind around this and note down the important aspects. For example, procedure, what do we need to do? We need an elective CT, which is short duration and painless. What are the current cardiac conditions? It's severe LVOTO and severe LVH. What are the challenges I have? The patient is from pediatric age group. He's a difficult patient. There are behavior abnormalities, which I need to take into consideration. And because of this, it's very difficult to take this child to the CT room. What are the critical cardiac conditions? There is outflow obstruction and difficult IV access. So these are my challenges, and how do I now address each of them? So environment is unfamiliar, so I always go with my check soap MI. And what are the possible complications? Acute cardiac decompensation. How did I do it? I selected the drugs with quick onset and offset, and I knew that analgesia is not required. It's just a short procedure for 2-3 minutes. But other task was to bring the child to the CT. So we gave him syrup midazolam to calm him down. So after that, he was quite cooperative. We brought him to the CT and we attached breathing circuit to his tracheostomy because he allowed us to touch that. And then we gave some SIVO, which further calmed him down, and then we could secure an IV cannula. Because he was a severe LVOTO, with SIVO, he had an abrupt fall in blood pressure, which was anticipated, and we were ready to counter that. So as soon as the IV cannula was in, we just resuscitated him with volume and some vasopressor, and he was fine after that, and we could do the CT. So if we know the specific lesions and we know how these lesions are going to respond to our anesthetic agents, we can be prepared to counter all those effects. In obstructive lesions, try to maintain SVR on a higher side, low heart rate, maintain the preload, maintain oxygen supply demand balance of the myocardium, keep your vasopressors ready, and avoid hypoxia, hypovolemia, rapid boluses of the drugs, and drugs causing vasodilatation. I prefer using ketamine, etomidate, remifentanil, and dexmedetomidine in these patients, but for this patient, we didn't have an IV access, and that's why we had to resort to sevoflurane. So there was another patient who was 10-year-old, 18.5 kilo, with both outflow tract obstruction, history of cardiac arrest in the past during anesthesia induction. Now he comes back with recurrence of severe biventricular outflow tract obstruction, came for MRI brain in view of recent onset seizures and cardiac MRI. So what was desired from us? It is a painless procedure, but it needed immobility, and it was a longer duration than usual MRI. So we decided to go ahead with TIVA, and we did ASA recommended monitoring. We had some discussion regarding having an invasive monitoring line for him or not, but we decided not to do that. We also discussed ECMO support for him just in case of any eventuality, but we tried to choose the safest anesthetic agents and the method for him. So we spoke to the cardiologist, and he didn't need any apnea. He was happy for us to maintain the spontaneous breathing. And we had a clear-cut hemodynamic goal to maintain the SVR, keep him on the slower side, low PVR, avoid drugs which can cause vigorous contractility to prevent SAM. So we chose TCI, propofol, and remifentanil combination, and we supported with a low-dose phenyl in the background. We had our crash cart ready, and team allocation was already done. In case if things go out of our hand, then who will remove the trolley from the MRI, and all the role allocation was already done. So this is how we could do that case comfortably. So this is again a real life example, and regardless of the background, whether you're from cardiac or non-cardiac background, any one of us can get caught in this kind of situation where, like, there was a 5-year-old boy, status post-fontan, came to an emergency room with hemoptysis, which was moderate, but it was continuous. So my anesthesia colleague, who's from general background, got a call from A&E doctor to have an IV access and CT scan for this boy. This boy was needle phobic. So the procedure is emergency, short duration, and painless. NBM status was appropriate. So what did my fellow colleague did? She called the cardiology and pediatric cardiac anesthesiology to offer her help, but nobody was free. So she took every detail of the child on telephone regarding his cardiac function, his plumbing, his operations, and everything. And Although the pediatric cardiac anesthesiologist could not support her physically, but he could guide her, like what were the do's and don'ts with single ventricle patient. And that's how it facilitated her to give the patient the mass CO, get an IV access, and then get CT done with ketamine and midazolam. So what were the hemodynamic goals in the single ventricle patient? To maintain the preload, because this is preload driven circuit, avoid causing any abrupt changes in the SVR and factors which lead to increase in the PVR, and maintain spontaneous breathing as much as you can. I would skip this case because of lack of time. So coming to this last case, there was a severe PH, 45-year-old man with severe PH coming for endoscopy. Now, what is desired? What is desired from the anesthesia? It's a shared airway, suppression of gag reflex, protect the airways. It was painless but very uncomfortable procedure. So we decided to go with TCI, remifentanil, and propofol combination. If you don't have remifentanil, it can be combined with dexmedetomidine, as long as we are trying to keep these things in mind, like avoid hypoxia, hypercapnia, hypothermia, catecholamine surges, pain, acidosis, and maintain the volume status. So we know what are the factors that can lead to acute severe PH crisis. If we can avoid that, maintain spontaneous breathing, maintain oxygenation, then the procedures can be done safely. So all these places, they are known and prone for complications like tamponade, respiratory depression, failure of ventilation, hypoxia, hypercapnia, laryngospasms, especially in pediatric age group, hemothorax, tension pneumothorax, arrhythmias, tachycardia, both, cardiac arrest, air embolism, and allergic reactions. So anesthesiologist needs to be trained not only in identifying, but also dealing with these complications. Now, how do we standardize NORA? The recommendation is that the institute should standardize protocols, and it can be developed by the proceduralist in collaboration with the dedicated anesthesia team, taking base local environment, equipment availability, general patient characteristics, and complexity of the patient of the procedure into consideration. All this can be supported by simulation drills, evacuation drills from CT, MRI, and audit of critical incidences and near miss events. So coming to the take-home messages, know your patient adequately, familiarize yourself with the pathophysiology, procedure, and place, set hemodynamic goals and appropriate monitoring, and match your drugs, choose your drugs to achieve those hemodynamic goals, have a robust recovery plan, and spend time in preparation. This is very important. If you spend time in preparation, you will have less time under anesthesia and less opportunity for the adverse events to happen. Thank you very much.
Thank you, Dr. Snigdha. It's a very detailed presentation. I think questions are at the end of the session, so
thank you very much, ma'am. Yeah. Thank you for the wonderful presentation and an excellent backup given to all of us in helping to organize this webinar. We would like to felicitate our speaker with an e-memento. Please accept the e-memento as a token of our love.
Thank you. Thank you.
So with this, we move ahead to our next speaker, Dr. Michael Schlamm. He is the citizen of US, born in Germany and living in New York. He has completed his medical schooling from Germany. He has done his fellowship in cardiac anesthesia and critical care from Schereit Hospital, Berlin. Currently, he is the director of cardiothoracic anesthesia at New York University Langone Medical Center, New York. Welcome, sir. I invite him to deliver this talk on perioperative management of patients with congenital heart disease for non-cardiac surgery, walking a tightrope. Over to you, sir.
Okay, somebody needs to show the slides. Because as usual, New York is the least advanced place of all. I wasn't able to show my.
Yes, we are sharing.
Yeah. Priyanka, if any problem from that side, I can share.
No, ma'am. Just give us
yes, please.
Yeah.
Please.
Okay.
I'm not able to. Okay, great.
Yeah. Slideshow.
Maybe I can move them here. Okay, excellent.
Make it full screen.
Okay, so can I, yeah, okay, perfect. Are you, okay. It's a little delayed, but yeah, okay, thank you for having me here. I enjoyed these first two talks very much. So I'm kind of going to talk, can you hear me all?
Very
am
clear.
I clear?
Yeah, very clear.
Yes.
We can hear you.
Okay, excellent. So I'm kind of following up on what Pompa and Snikta had been saying, expand on a few things and zoom in on some specific aspects. I will talk about building a congenital program, which is sort of the experience I had here in New York. Then some management principles in children and adults also with congenital heart disease. And then at the end, I will discuss some specific lesions and also give some clinical examples. So it's clear, of course, that the cardiac patients are being taken care of by, can you, I don't know, I can't advance the slides, it's not doing it. Can you advance the slide?
Yeah, you just say
okay,
next.
thank you.
So we can advance it. Yeah.
Okay, I'll do that. Okay, perfect. So it's clear that the cardiac cases are done by cardiac anesthesiologists, of course, but for non-cardiac cases, I think this is not so clear, and it depends a little bit on the institution. There's a lot of debate about it. The notion that specialized anesthesiologists should be used is supported by data from the Pediatric Peri-operative Cardiac Arrest Registry, in which 373 anesthesia-related cardiac arrests in children were reviewed. About a third of them had heart disease, and more than half of the arrests occurred outside the cardiac operating room, suggesting that non-cardiac surgeries or non-cardiac anesthetics in cardiac patients are associated with an elevated risk. Next, please. So the type of procedures, this is data out of Boston Children that are done in these type of patients include ENT procedures, radiology procedures, and general surgery procedures such as G-tubes, laparotomies, and so forth, on and so forth. This is the bulk. But there are other procedures, of course, orthopedics, GI, urology, dental, and so on and so forth. So you can see a congenital patient virtually in any operating room. But ENT, radiology, and general surgery is the largest part, and that is very consistent with our experience. Next. Next slide, please. So next. Okay, yes, thank you. So the resources a hospital have are unlikely to be unlimited, and therefore it is necessary to assign the proper anesthesiologist to the right case. And that comes down to proper risk stratification. There's an abundant literature on this topic, and most papers divide the congenital patients into 3 risk groups. There is the low risk groups, older than 1 year, without anesthesia-relevant comorbidities, that has near normal cardiac function. These include ASDs, VSDs, and some repaired lesions. The moderate risk group is also older than 1 year, no comorbidities, but now has more severe functional abnormalities in the heart. These are mainly corrected lesions with residual defects. And the high-risk group is everything else, all age groups with and without comorbidities, and patients with severe cardiac dysfunction, including uncorrected lesions, pulmonary hypertension, and severe ventricular dysfunction. So the question is, next slide, please. The question is now who should take care of these patients? So the conventional approach followed in most hospitals is that the high-risk group is being referred to a pediatric cardiac anesthesiologist. However, I would say this depends very much on the institution. It depends on the patient population that you have. And as Snikta already alluded to, also on the experience of your staff. It depends on the facility, how easy or difficult it is to get help, how far are people away from each other. And it depends to some extent also on the parental expectations. In New York, for instance, a lot of parents come with their children and say, this child can only be anesthetized by a cardiac anesthesiologist. And it is sometimes difficult to sort of readjust their expectations to explain to them that this may or may not be necessary. Next slide. So we are a mid-size teaching hospital at the east side of Manhattan. Our children's hospital is fully integrated within the adult hospital, and most of us give anesthesia both to children and adults. What you see there in the back is not a traffic accident, but a large statue of a dog that's balancing a real-size taxi cab. That was built there to make the children excited to come to our hospital. I'm not sure that works because they still cry when we come, but it looks cool. Next slide. So we have, we perform about 250 pediatric heart surgeries per year. So it's sort of a mid-sized volume, 400 EP and cath cases. We have 20 ICU beds, and we have 4 pediatric cardiac anesthesiologists. And we have 2 general pediatric anesthesiologists with significant experience in dealing with patients with congenital heart disease. So between those 6, we handle all the non-cardiac cases. What we do is pretty much what I showed you in the previous slide: G-tubes, laparotomies, PICC line, laryngoscopies, and MRI procedures. Next slide. Our risk stratification is not inconsistent with what the literature suggests, but it's rather simple. It's sort of a little bit simplified, I would say. What we do is that we refer all patients with single ventricles, with cardiac right to left shunting, and with severe cardiac or valve dysfunction to an anesthesiologist with specific CHD experience. And everything else goes to the general group. Next slide. Okay, so a few words about managing patients with congenital heart disease. The key aspect of managing patients with congenital heart disease is to balance pulmonary and systemic blood flow, because they frequently do have intracardiac shunting. And blood has a choice between flowing into systemic or into the pulmonary system. The anesthesiologist can do a whole lot to help rebalancing blood flow. High inspired oxygen and hyperventilation resulting in low CO2 will increase pulmonary blood flow, and low inspired oxygen and hypoventilation resulting in high CO2 will increase systemic blood flow. These are the principles, this is the core principle of managing patients with congenital heart disease. And that has to be sort of ingrained in anybody who takes care of congenital patients. So next slide. The question is, what is the ideal saturation in a patient with complete intracardiac mixing? So the answer to that question can be easily calculated from the following numbers. The saturation in the blood returning from the pulmonary veins is normally 100%. And the saturation of venous blood returning from the systemic veins is, if everything else is normal, the cardiac output is normal and the hemoglobin is normal, is 70%. And if the two mix 1-to-1, your saturation will be 85%. So it's a first good guess to say that a saturation in the mid-80s is ideal for patients with intracardiac mixing. Everything above 90 should be viewed with suspicion because there is a potential for pulmonary overflow, and everything below 80% could represent pulmonary underflow. Balancing these two circulations is, in fact, what is the is the core responsibility of a congenital anesthesiologist. Next slide. So if there is a large imbalance between between systemic and pulmonary blood flow, the child may either experience compromise of gas exchange or a frank cardiac failure. And the latter is explained here because congenital patients require a slightly different way to look at the concept of cardiac output. So in a normal patient that does not have congenital disease, if we are saying the cardiac output is X, what we mean is that the RV output is X and the LV output is X. So the total output of the heart is actually 2X. So in an adult, 5 liters per minute would be 10 liters per minute. Now in patients with intercardiac mixing, like a double outlet right, where the pulmonary to systemic perfusion ratio could be far away from 1:1, it could be 3:1, for instance, or even higher. If we are maintaining normal systemic perfusion, 3 times of that blood flow will run through the pulmonary system. So the total cardiac output here is 4X, which is twice as high as it should be. And the patient that experienced that condition is at risk for sudden heart failure on induction of anesthesia, as I can show you here in the next slide. Next slide, please. Yes, so this is a case that I did a few years ago where I made a mistake that almost led to a bad outcome for that patient. This was a 3-month-old infant with a BT shunt that presented for PICC line placement to the IR suite. I induced inhalational anesthesia with sevoflurane, placed an IV, paralyzed the kid, and then placed an LMA, expecting it would be a short case. I maintained anesthesia with sevoflurane and oxygen. So initially the case proceeded smoothly, but 30 minutes after induction, the baby experienced hypotension and ST depression. I treated that with a little bit of epinephrine, and then eventually realized the mistake that I had made and interrupted ventilation, and things stabilized and came back to normal. So what had happened here, this child had some pulmonary overflow. And I, by not paying attention, had kept the kid on 100% oxygen unnecessarily. And this pulmonary overflow got worse and worse and worse over time, and eventually resulted in heart failure and a drop in systemic perfusion. So in my defense, I have to say this is not common in BT shunt kids because initially after surgery, the lungs are inflamed, and the pulmonary vascular resistance is elevated, so they are usually protected from that. And then they quickly outgrow this size of their BT shunt. That means that the baby grows, but the BT shunt, of course, doesn't. And therefore, again, we are protected from pulmonary overflow. But this child was probably just in between these 2 phases. So the 2 key messages are here. Number 1, never use more oxygen when needed. Oxygen is a drug. It should be used, of course, but it should be just used as much as necessary. And in this child, it was not necessary to give 100% oxygen. And number 2, always be on the lookout for imbalances of pulmonary and systemic perfusion. There's always a possibility in all children with shunts. It can go towards pulmonary overperfusion or underperfusion. And a child can swing from one state to another within minutes. Next slide. Next slide. Okay, so here are a few practical aspects. We do all our non-cardiac cases in congenital children with standard monitors, no A-line, just non-invasive blood pressure, EKG, and pulse oximetry. Very simple. I use for anesthesia sevoflurane, fentanyl, and rocuronium. I'm not saying that's the only thing you should use, but that works and that's simple. Fluids and drugs are given through a push line that is shown down here. That's like a 60 cc syringe connected to a manifold, connected to a tubing. Then I have a side syringe to trap air. So all fluid goes first in that side syringe that's being held upright. So air traps at the top. And then everything is sort of made air-free, which is important, of course, because each bubble of air that is being entrained in the venous circulation can end up in the arterial system. For each case, even for the most benign case, the shortest case, I will always have emergency drugs available, drawn up before I start the case. Epinephrine in 2 concentrations, 1 and 10 mics per cc, and some calcium and lidocaine. Okay, next slide. So now at the end, I will, next slide, please. Mention a few conditions that, some specifics about these conditions. Some of them were already mentioned in the previous talks, but I will expand a little bit on them. So first condition that you may encounter is the Williams syndrome. This is a large variety of different lesions, but the one that is most important for anesthesiologists is the supraortic stenosis, because it pressurizes the coronary system. And those children that have pressurized coronary system are very vulnerable to sudden drops in blood pressure, because the coronaries are used to seeing a high pressure. And if this pressure drops, they can become ischemic very quickly. Those patients, it is important to have tight hemodynamic monitoring to establish IV access very early and to treat hypotension aggressively. Next slide, please. Next slide. Hypoplastic left heart with interrupted arch is a common condition. Here, almost all the blood volume that the heart's pumping is coming out through the pulmonary artery, both for the systemic and for the pulmonary circulation. For the pulmonary circulation, it goes down into the branched PAs, and for the systemic circulation, it goes through the ductus arteriosus into the aorta. Those patients are very sensitive to high inspired oxygen, hypotensive very, very quickly because of pulmonary overcirculation. Similar problem, what I mentioned before. So those children should not be placed on 100% oxygen at any time, maybe very briefly for intubation if you want to give you a little bit more time, but in general, they should be kept on room air. Next slide. Gland circulation. Here the SVC is connected directly to the pulmonary artery and is the only source of pulmonary blood supply. These patients benefit from a slightly elevated carbon dioxide because it increases cerebral perfusion and therefore augments the amount of blood that's returning through the SVC into the pulmonary circulation. After the case, these children should be placed in a head-up position in order to allow proper drainage of head blood into the pulmonary circulation. Next slide. Fontan circulation was also mentioned here, already by Snigdha. Just here, again to the non-specialists here, this is a surgery in which both the IVC and anti-SVC are connected to the pulmonary artery. Patients do very well. We have a lot of patients with that type of circulation, even adults, because they actually do very well and grow into adulthood. One important, it's rather easy to give anesthesia to them. They are quite stable in general. But there's one important thing one has to know, namely the fact whether or not they have a fenestration. And the fenestration is a connection between the IVC and the common atrium that allows blood to flow over and bypass the lung. So in patients with fenestration, a sudden increase in pulmonary vascular resistance will cause excessive hypoxia. But it is sort of benign hypoxia because it's hypoxia as a result of intracardiac shunting. So the patient gets blue, but remains overall stable. So that has to be, the anesthesiologist has to know that. In the absence of a fenestration, however, a sudden increase in pulmonary vascular resistance will cause hypotension, which is actually a lot more dangerous because blood cannot easily cross the pulmonary system and the common ventricle empties out and the stroke volume goes down. So those two things need to be distinguished, and it's important that before you start an anesthetic that you know whether or not this patient has a fenestration. Next slide. Tetralogy of Fallot, it's generally well known how to deal with those patients. We have a VSD that allows intracardiac shunting, and they usually have some sort of RV outflow tract obstruction that then drives the shunt primarily from right to left. The key point in those patients is that in many of them, not in all of them, but in many of them, the RV outflow tract obstruction is very dynamic. That means it is not a fixed anatomic obstruction, but one that depends on the muscular tone and on the filling. Sudden onset of hypoxia as a result of right to left shunting is often triggered by hypovolemia or sympathetic stimulation, which are two conditions that are quite possible in the perioperative environment. You can read in any anesthesia textbook how to treat that, but apart from knowing how to treat that, I think it is important also to know the sequence of what you should do. So simple things first. The first thing one should do is to administer fluid, because sometimes it is just the kid is just empty and it is hypovolemic, and that will fix the problem. One should increase the depth of anesthesia in order to reduce the sympathetic tone. And only then should one consider more aggressive steps, such as the administration of vasopressors in order to increase SVR, in order to drive blood back from the systemic into the pulmonary system, or beta blockers in order to relax the musculature. Next slide. So before I finish, and this is now, I promise, my last, the last couple of slides, I want to present a case. This is now a cardiac case, so it's a little bit off topic, but it is a case that demonstrates the significance of hypoxia in patients with congenital heart disease. And I think that's one of the most important concepts in taking care of these patients, inside and outside the cardiac operating room. So this case was I think we did it last 1 or 2 years ago, I don't remember. So there's a 7-week-old baby that was born prematurely with tetralogy of Fallot, just what I showed you. So it came to the operating room with the plan to close the VSD, to augment the ASD, and to perform a transannular patch repair. So the kid was placed on bypass. And at the end of the bypass run, I read an echo, and the echo showed that there was good repair, looked excellent, but there was poor biventricular function, probably because of the relatively long bypass run, or from something else. We didn't know. So we went back on bypass and rested the heart for about an hour, and then successfully separated from bypass. So I was quite worried about this kid because of this relatively long bypass one, but everything after that in the operating room proceeded rather smoothly. Next slide. Next slide. Right before we left the operating room, the last blood gas was pretty unremarkable. But then on transport, the kid got visibly bluer and bluer. And the first gas in the ICU, now after midnight, almost 1 o'clock in the morning, showed a pH of 7.2, a PCO2 of 56, and a PO2 of 16, with a measured by oximetry measured saturation of 30%. Basic says -7. A lot of hemoglobin, 18, and a lactate of 3. So this was quite hypoxic, of course. Everybody was worried. I was worried too, I will admit, but something told me that the child was actually doing well. Because the most dangerous part of hypoxia is if the kid is not ventilated. And we all know that if babies are not ventilated, they deteriorate very, very quickly. But this baby was rock stable. What had happened here is that because of the large ASD, blood was able to shunt from the right to the left side. And the baby, because of the long bypass one, had experienced a progressive increase in pulmonary vascular resistance. So this baby was getting very, very blue. But the baby had gas exchange, which is documented by the fact that the CO2 was only slightly elevated. It had sufficient gas exchange, and that's why this baby was stable in this situation at that low saturation. We then performed a little bit of lavage, gave some nitric oxide, and the SAT came gradually up, and this baby did actually very well. So it is absolutely important to understand the cause of hypoxia in children with congenital heart disease. It could either be from the lack of ventilation, which is very, very dangerous, or it could be from intracardiac shunting, which is much more benign, although it also may require some intervention. Next slide. So the key points here is there is large discrepancies between PO2 and PCO2 are indicative of intracardiac shunting. Hypoxia in and of itself is not necessarily life-threatening, but the lack of ventilation, the lack of gas exchange, of course, is immediately life-threatening. Lactate, and that's an important point here because I think lactate was mentioned earlier, lactate does not rise as a result of hypoxia. This is sort of misinformation that had made its way into the medical literature. Lactate rises as a result of hypoperfusion because lactate gets eliminated in the liver, and the liver is hyperperfused and lactate rises. So in this child, you could see in the previous slide that the lactate, despite of this high level of hypoxia, remained very low throughout the entire procedure. Next slide. And this is now indeed my last slide. This is me with my monkey. So I'm using this monkey to keep the kids happy. This may not be so funny in India because you have a lot of real monkeys there, but we in New York, we don't. Thank you very much.
Thank you, Dr. Shlam. It's, I think each and every slide, what you presented was so very important, not only for general anesthesiologists, but also cardiac anesthesiologists. It was a pleasure to listen to you. Thank you.
Thank
you. We have a few questions.
Thank you so much, sir, for the comprehensive and elaborative talk. We would like to felicitate Dr. Michael Shlam with e-memento. Please accept the e-memento as a token of our gratitude, sir.
Your presentation is not there. Yeah.
Now moving ahead towards the question and answers, I request the chairpersons to kindly take the question and answers.
Dr. Jaswant is there. Hello, Dr. Jaswant.
Hi.
Yeah. So I think there were a few questions in the chat box which Dr. Pompa has already answered. A couple of them were missed. I think the first one was by Dr. Yatharth about the arterial line, and an absolutely valid question when you're working in freelancing private practice where you don't have access to a lot of simple things like monitoring kit for arterial line. Which are the cases? The question is, which are the cases where you would actually put it, and is it absolutely mandatory to do it? And then I think the next question is about peripheral pulses, CRRT, or for the perfusion monitoring. Probably these two questions go hand in hand. If you could just answer them, that would be great.
I think it has already been probably touched on in terms of the previous talks by Snigdha. So I think in terms of invasive arterial monitoring, it's based on your risk assessment, and it's on the type of procedure you're anticipating, how long, how stable or unstable, what is the cardiac physiology you're dealing with. I think it's very difficult to be prescriptive, and I think you need to make the judgment on a case-by-case basis. Obviously, if you think, for example, in the first case where you have seen biventricular outflow tract obstruction, so that case can actually destabilize quite rapidly when you induce them. So in that case, I think an arterial line probably is beneficial. Similarly, we do routinely use arterial lines in our post-op cardiac patients. Also in our shock patients where there is no response to inotropic therapy. But again, it's dependent on what risk are you anticipating? What are your anesthetic risks? I think that's how I would like to rationalize the situation, essentially. And again, as you saw, the arterial line is not without its own risk. And again, damping, underdamping the artifacts, those need to be dealt with. So I think no monitoring is perfect. But I think it's important to know how you interpret it and what are the limitations of each monitoring device. And coming to your next question, I think it was about capillary refill time. Is that what your question was?
Yeah.
Now, I think there exists controversy in literature about the accuracy of capillary refill time, though, I mean, it's in most of our guidelines. If you look at your PALS or APLS guidelines where they recommend monitoring cap refill time for hyperperfusion. But the problem is it varies with your ambient and skin temperature. So if it's hypothermia, you can have a prolonged capillary refill in the peripheries. The central refill may be okay. And so I think the peripheral cap refill, I think probably is not that useful, if you ask me honestly. But if you have a delayed central refill, I think that may give you a bit more clue that actually you're kind of, you're in a shock state. But however, I think that there's recently been an Andromeda shock trial, which has shown that they can use CRT for kind of, that it extends beyond diagnosis, and they have used it in the resuscitation phase. So I think there is some benefit to it. But again, as with all monitoring, it's important to integrate all the variables that you have to, it's kind of creating a story, essentially, is how I look at it, that you kind of make a picture of all the numbers that you have and then put it into context.
Yeah. Thank you, Dr. Pompa.
Does that answer your question?
Yeah, I think so. Yeah, I think it's very much, I would just like to say, as an anesthetist, most of the time we would also go by the pedal pulses. A cap refill is one thing, and pedal pulses, it's like a poor man's monitoring, where you can just feel the pulses dorsalis or posterior tibial, and you are assured that you can leave the patient and go to your next case, when you're in a private setup. So, and that's a point I would like to add on to. Dr. Jess, you would like to say something?
No, I think, again, going back to arterial lines, I think Pompa's right that obviously they've got their risks, and I work in the same unit as Pompa, and some of those pictures I've seen. So again, it's just sort of making a judgment call, isn't it, depending on the case. So in our OT, all our patients would get an arterial line because of what we do in terms of cardiac. But it's just about in the outside setting. And I know that with Snigdha's talk and some of the cases that we do in cath lab, etc., we end up putting arterial lines in. But so I think it's just sort of weighing up the risks versus the benefits for each individual case.
Yeah, I have one question for Dr. Snigdha, and that's from my side. Are you around, Dr. Snigdha?
Yeah, I'm here. Yes.
Yeah, it's just that when you're doing this cases, especially suppose an anesthetist gets a call for an MRI, cardiac MRI, or say a cardiac patient for a non-cardiac MRI. MRI suites, they take a long time, and then they're more claustrophobic and all. And sometimes things can go wrong. Do you recommend to have an ICU backup for most of the cases, or suppose if it's a cardiac MRI or a non-cardiac MRI, or because probably the people may not be in the same hospital. The cardiac MRI setup might be different, and a closest hospital would be different. So would you refuse that case, or would you say, no, I will keep a backup of an ambulance to shift the patient and alert the intensivist, Dr. Pompa, maybe for that matter in your case? So how do you go about it?
So again, going back to what Jess said, like we were fortunate and we're lucky enough that we have our MRI in the same building. So there's a long way to through the basement to the MRI, but still it's the same building. So that is an assurance. And then if I ask for a backup support, again, it depends on the pathophysiology of the patient. If he's a really high risk, like this patient I mentioned, biventricular outflow tract, for this patient, I definitely had a bed booked, although I didn't intubate or didn't do anything on his airway. But all these high risk patients who for their recovery, if I feel it's unsafe to keep them in the MRI recovery, I always ask for an ICU bed, but not routinely, because most of the patients, approximately more than 50% of the patients, they are either repaired and they're just on a follow-up MRI and they are doing well, or they have minor residual lesions which needs to be addressed. So these kind of patients, and if they are not syndromic, no airway issues, no other comorbidities, then I do not ask for an ICU support. But if there is deviation from any of these factors, anything extra to this, we definitely ask for an ICU. And sometimes we even cancel or postpone the case if we don't have backup ICU support.
Yeah, it's like gets me to a point where Dr. Shlam mentioned he has beautifully decided which cases are going to go for a general anesthesiologist with pediatric background, and it's the most difficult algorithm to have in an organization, especially more difficult when you come into private practice where you want to refuse or you don't want to refuse a case based on the cardiac thing. So, I think just to summarize it from my side, and of course, Dr. Jaswant can add his points to it. For an anesthesiologist, you have 5 relevant things which you can ask before starting any case with so-called cardiac thing in that. One is whether it's a single ventricle or it's a 2 ventricle. And again, why I say that, because most of the anesthesiologists have devised their own thing of how they would approach a high-risk case. Some would put a central line, some would put 2 pulse oximeters, some would probably keep an ICU backup, some would probably take a high-risk consent. So each anesthesiologist would have tailor-made his own high-risk protocol. So I would say these 5 questions, if you ask yourself, you yourself can categorize which patient you want to put in the high risk and which you don't want to. Probably the first is whether it's single ventricle or a 2 ventricle. Of course, the high risk is single ventricle. The second would be probably if it's a corrected lesion or it's an uncorrected lesion, then obviously it's an uncorrected lesion, which is high risk. The third would be probably cyanotic or acyanotic. And I think both would be more or less the same, because, if there's an increased pulmonary blood flow, then even that's a risky thing to have. The fourth would be whether it's a palliation, like shunts or other things, or if it's a total correction. And again, palliation is more riskier than total correction. And last would be whether you're seeing a major case or a minor case. A minor case obviously would be a low risk, a major would be a high risk. But again, a case like endoscopy, which you said, where you're sharing the airway, it can be, but you cannot push for a central line or an art line. In that case, the gastroenterologist wouldn't like it. So I mean to say, you can yourself come to an algorithm and make a very clear policy on how do you want to approach. And I think that I would like to summarize it this way, this session, it's been beautifully covered by all 3 of you. And Dr. Jess, if you want to add anything further.
Yeah, I completely agree with you. I think that's a good way to sort of summarize high risk, low risk. So we have a system in our hospital, and Snigdha will tell you, sometimes me and her will disagree. And, like you said, each anesthetist will have their little quirks as to which one's more high risk. But in terms of what we let our general peds anesthetists do or what they do, we've developed a link, and we've developed a link person on that side who then sort of looks at all the cases that we feel they can do. And then we try and cross cover and help each other out. But that's one of the ways that we've developed it in our institution.
Yeah. Thank you. Dr. Shlam, you want to add anything further?
I mean, I think the key thing is to make it simple, right? I mean, in a university hospital where you have a lot of anesthesiologists, it has to come down to simple rules, because especially at 6 p.m, everybody wants to go home. So there has to be a rule who is going to do this case or that case, right? So if you have a complicated set of rules, I don't think that's very practical. So that's why we had this simple system, So certain conditions have to go to a CHD anesthesiologist. That's usually my group and 2 other people that are well trained in those. So they have the necessary experience. But everything else has to go to the general group. They have to, they are very good anesthesiologists also. And there's no reason that they shouldn't be doing these kind of cases if it's appropriate. At 6 p.m, or even at 8, if necessary.
Yeah. Thank you, Dr. Shlah. I think we are okay with this session. If anyone wants to add anything, or think we should conclude it.
I have a question for the anesthesiologist in this group, because most of the times we are involved in MDT discussions, and the way our services are organized is we kind of cater to different hospitals. The cardiac services are kind of centralized to the East Midlands, for example, where I work. Now, like pulmonary hypertension in kids or adults, like, some have reactive pulmonary vascular reactivity, some have fixed pulmonary hypertension. And a lot of times from an intensivist perspective, I have difficulty in moving patients out who, for example, came to my center for a cardiac surgery, but has some other issues like, something like needs an airway assessment or needs like a PEC tube or gastrostomy. Like, how do you risk assess? Because then it's like once they're corrected, they can, from my perspective, they can be moved out and, once I'm extubated, like, or can be ready to step down. But often that seems to be a barrier, like that, the child has behaved like, has got PVR issues. Is there any way you risk assess that? Because I think that is important in terms of like pulmonary hypertension is kind of within quotes that becomes pulmonary hypertension then, whether it's fixed or not fixed.
So to answer your question, usually when the left or right shunts are repaired in time, the pulmonary hypertension is supposed to resolve within 6 months' time. Like, it comes down its reactivity and comes down to baseline. And if it was not fixed pre-operatively, like if we tend to operate a lot of borderline cases or even those cases who are on the borderline of isomengerization, especially in India. So these kind of patients will always have a residual PAH. So they come into high risk category, but all these kids who have their operation in time, so we expect their pulmonary hypertension to settle down within 6 months to 1 year's time. And also the clinical behavior will guide you. This will be the best guide if child is doing well and gaining weight and nourishing well. So that again, and his activities and everything is fine. Again, it's a pointer towards like he doesn't have an element of PAH. So that's how natural progression of any left to right shunt baby who's operated. And I wouldn't fear after 6 months of repair, I probably wouldn't fear of any PAH crisis of anything, unless there are some specific signs and its specific considerations. For example, a Down syndrome child, he even after repair, he can have, this kind of child can be a high risk for PAH, which might not subside even after the repair. Mm-hmm. So it depends on what kind of patient we are looking at. Does that answer your question, Pompa?
It does. It's just that we are not able to create beds or kind of create flow because of this, because then a general anesthetist doesn't want to anesthetize them, and it then has to be a cardiac anesthetist, so I think it needs more, probably it's more about education rather than anything else.
Exactly.
Okay, I think we go ahead with the next session.
Okay.
Yes.
We are running out of time.
Yep. Thank you.
Thank you. Thank you so much.
Thank you, Dr. Sachin Patil and Dr. Jaswant Sumal. It was indeed a very informative session. We would also like to felicitate our chairpersons with the e-mementos. Dr. Sachin Patil and Dr. Jaswant Sumal, please accept the mementos as a token of our gratitude. So now moving ahead to our next session. The chairpersons for this session are Dr. S.K. Deshpande, sir. Dr. S.K. Deshpande is a cardiac anesthesiologist and intensivist since 1988, pioneering efforts to establish cardiac anesthesia programs in Nagpur.
Priyanka, a lot of echo from your side. Please mute other devices.
He is the president of Cardiothoracic Society, past chairman ISACM Nagpur chapter, past president ISA NCB, ex-GC member IECTA National and ISA Maharashtra State. He has been faculty in more than 50 conferences, and he has been the organizing chairman, scientific committee member, Visacon, mechanical ventilation workshop. He has actively participated at Rotary's Melghat surgical camps, and he has also visited Kailash Mansarovar. Our second speaker, second chairman for today is Dr. Vinay Kulkarni, sir. He has done his MBBS, DA, DNB, FNB, and overseas fellowship in intensive care at St. George Hospital, Sydney, Australia. He has been executive member in SCCM, Nagpur chapter, and secretary of Cardiothoracic Society. He has conducted various workshops like BLS, ACLS, and mechanical ventilation. Presently, he is working as a consultant cardiac anesthetist and intensivist since 2010 in Vidarbha Anesthesia and Critical Care Associates. He is also the founder member of this association. Welcome, sir. And our next speaker for today's webinar is Dr. John Benz. Dr. John Benz is a consultant cardiothoracic anesthesiologist at Glenville Hospital, University Hospitals of Leicester, UK. He is also the honorary senior lecturer at University of Leicester, Faculty of Life Sciences. He is the chairman of European Association of Cardiothoracic Anesthesia and Intensive Care Echocardiography Subcommittee. He is also the member of this subcommittee. He is the UK representative on Representative Council, European Association of Cardiothoracic Anesthesia and Intensive Care. He is the member of EACVI, ESC, and European Association of Cardiothoracic Anesthesia and Intensive Care Certification Committee. Welcome, sir. I request the chairpersons to take over the first talk of this session, which is on perioperative management of patients with coronary artery disease for non-cardiac interventions, putting the jigsaw pieces together, by Dr. John Benz. Over to the chairpersons.
Thank you. And thank you to the ISA-NCB and the Shalini Mege Institute of Medical Sciences for giving us an opportunity to chair this session. And today there are two important talks. And first talk is by Dr. Johan Benz on perioperative management of patient with coronary disease for non-cardiac intervention, putting the jigsaw pieces together. And I think the coronary artery disease has really increased by leaps and bounds in India, and with increased diabetes, the CAD incidence has further increased. And every now and then we are encountering these cases for coming for non-cardiac procedures. We have got a very accomplished speaker in the with Dr. Johan Benz, and without wasting much time, I request him to please begin his talk. Thank you.
Hi, everybody. I'm just going to get this on the screen, and then we can start. And firstly, I want to thank the organizers. Sorry, just want to get out of this. It's great. Just get to the first slide, and thank everybody. Just say good morning, good afternoon, and good evening to everybody. And I would like to thank the organizers for inviting me and congratulate them on the contents, and also congratulate the previous speakers on the absolutely excellent contents of all the talks. And it's great. I've learned a lot today, and I've really enjoyed being part of this. So what I've been asked for is to speak about the perioperative management of patients with coronary artery disease for non-cardiac surgery. As you've heard, I'm just going to divide this up in a couple of things. I'll just cover the prevalence and the incidence of ischemic heart disease in the world and in India. Is it important? We have to decide. And we've heard from previous speakers and during the introduction today that yes, it is important. We're going to see what the impact of ischemic heart disease is on anesthesia. What the role does it play in our lives? Look at the risk stratifications and all of the different risk stratifications that are available. We look at the perioperative or the pre-operative approach first. Anesthetic techniques have already been discussed greatly. And then we look at a little bit at post-operative care and post-operative outcomes as well. Just about the prevalence and the incidence of ischemic heart disease, it's the leading cause of death worldwide. There's 126 million individuals at the moment in the world that dies every year of heart disease. And you can see it's got a huge impact. 165, say, 1,655 per 100,000 people that actually die of ischemic heart disease. It's 1.72% of the world population, and it's projected to become worse, up to 1,845 by the year 2030. And it's the #1 cause, sorry again, of death, disability, and human suffering globally. Just a quick, to come back, just to explain the difference between prevalence and incidence, just to make it clear. Prevalence is the proportion of persons who have a condition, and incidence are the proportion of people that develop the condition, just so that the next few slides can make a little bit more sense at all. Just again, to just put it in perspective, you can see on this, I'm just getting my, that what the global is, as I said, 1,655, the rate per 100,000. The disability, the dailies are is almost double that. You can see the numbers here. In India is lower in perspective, but we must remember that the reporting is much lower. Just to see what's going on in Europe, which is basically the capital of deaths on cardiac disease. You can see 4 million people that die per year. That makes out 47% of all deaths of ischemic heart disease. You can see here in the United States, 15.4 million people age over 20 have ischemic heart disease, which is 6.4% of the population, and with a predominance due on men with that. Here you can more or less see on this side is the incidence of the heart disease, just so nicely distributed. So just for our own knowledge, we can see where this in the age groups where this is the most prevalent, and we can see that it starts at around about the mid-50s and then go on until to the 80s. I'm not going to go into detail with this, but these graphs showed nicely, and also the difference between male and female patients. Just the percentage of the risk factors, what plays a role in the risks, and what do we have to look at when we approach these patients. And you can see it's more what we eat than actually how much of that we eat that actually influences in the world as a whole the risks for deaths. And you can see that even things have also got a big different effect on men and women. And this is the global risk factors that we show here. If you look at India as a separate entity, this is quite revealing. And that is, India on its own accounts for 1/5 of the 17.7 million deaths worldwide. So 2.26 million deaths in 1919, in 2020, 4.77 million deaths. Cardiovascular death rate of 272 per 100,000, and the global average is 235. What's important here is that cardiovascular disease strikes the Indian population a decade earlier than the Western population. So people get sicker younger. And this early onset and the rapid progression and the high mortality rate is not explainable by the conventional risk factors. And you can see in 2016, cardiovascular deaths contributed to 28.1% of total deaths in India, and also 14.1% of the total dailies. And this has come up a lot since 1990. And as the population, and you can see here, which is important in the UK and the USA and Europe, is that migrant Asian Indians has got a 3-time higher prevalence of coronary artery disease as a subgroup than the native populations. They are hospitalized 2 to 4 times more frequently for complications of coronary artery disease. And what's important is the age, as the admission rates are 5 to 10 times higher for populations younger than 40 years. So quite a lot. And you can see on this spread of demographics, which shows the Southeast Asian population against the world population as such. The risk factors in India is not very different from the rest of the world. Smoking, diabetes. What's interesting is just the emerging factors, the high homocysteine levels, ambient air pollution, the variations in outdoor temperatures, and psychosocial factors, obviously mental health. And then there's also a higher sensitivity for C-reactive protein from these patients. You can see the risk factors in India, again here, where the overweight in the green line, hypertension, you can see in both in the overall as well as in and in the Indian population, these play with diabetes a major role. Just the ischemic heart disease in anesthesia. Does it have an impact on us in anesthesia? And you can see here, every year, 4% of the world population will undergo a surgical procedure. And 30% of that will be major surgery in the context of at least one cardiovascular risk factor. And you can see the numbers here. This is people on the risk factors. This is proportions both right and left here. 1.1 cardiovascular risk factor, 2 risk factors, and the black ones are the 3 risk factors, and the percentage make out from the people presented for anesthesia. Perioperative myocardial infarction will occur in 3% of the patients undergoing major surgery. The 30-day mortality rate for these patients is only 0.5 to 2%, but if you allow them to go into heart failure, then the mortality goes up to 8%. And you can see here we look at all causes mortality versus cardiovascular death in patients that present for anesthesia. So it is very important. So how do we approach this? And now there's several ways that we can approach the, and look at patients perioperatively. You all remember from all the Goldman risk indexes and the Lee indexes. This one is basically the one that is mostly used in the world at the moment, that should be used. And it looks at all the risk factors, or the major risk factors that play a role, as you could see on the previous slide: cerebrovascular disease, congestive heart failure, creatinine, renal disease, diabetes. Each one of these gets 1 point. And then if you look at the 0 points, then the risk factors about 0.4%, 1.9%, 6.6% risk, and more than 3 point, your risk factors go up to over 11%. And that risk is the risk of cardiac death, non-fatal infarction, and non-fatal cardiac arrest in the perioperative period. So you can see that this is a group that we will get and we will see. And if we look at that, we will probably find that if we work in that middle group in the age between 50 and 80, which is a bulk of our patients in modern anesthesia, adult anesthesia, then if you look at that, then at least 1 out of every 5 patients that we do will have ischemic heart disease. These are the risk factors by the American College of Physicians, and there's several things. That's more historic risk factors. If you look at the physical and the clinical risk factors, then we see these, major cardiac risk, and these just are mostly common sense. A patient with unstable coronary syndromes, your really sick patient, decompensated cardiac congestive heart failure, or arrhythmias, or severe valvular disease, they are high risk, and there's no doubt about this. All of these are really commonsensical risk factors that we can have. The one thing that's very important is diastolic dysfunction, and that we have to look at very critically. Because this is probably one of the emerging factors from a clinical point of view. That's a big factor. It's one of my high points that I look at diastolic dysfunction and the left ventricular end diastolic pressure. The higher that is, the least the oxygen delivery to the left ventricle is, and the higher your incidence of myocardial infarction or perioperative ischemia. So that makes a lot of sense. So these patients are, one of the things that are not in the risk assessment is the factor of diastolic dysfunction. If you have any patient that you have got any report of diastolic dysfunction, you immediately have to be aware of perioperative ischemia. Just The next factor that comes in obviously is what type of operations we are doing, and you can. This is just the guide from the guidelines, and you can pick where your patient's operations fit in. Which of these are the anesthetics that you are given in any of these operations? Obviously, I'm not going to go through all of them for the sake of time, but you can see that your intermediate risk is 1 to 5%, and your high risk is operations have creates a higher risk of more than 5% for your patients. And it's sometimes surprising if you have these to see where your operations fit in. There's different classifications. This is the one from the American College of Cardiologists, which have got a different level of risk appropriated to each risk. I'm not going to go through all of these separately. Just to start off with a typical patient that we had, and that I had a couple of weeks ago, 52-year-old lady, fit. She walks her dog every 5 miles. She is an ex-smoker, which is done suddenly a small risk factor, and she had a sudden onset of tiredness and shortness of breath. She felt like she had been punched in the back. She struggled and she worked for about 2 weeks after that, but she couldn't cope with her work. And then she went to a GP who took an X-ray, and she had a big pleural effusion on the right and a small one on the left. She went for CT scan, and they found a big pericardial effusion. So the diagnosis was made that she must have an infection, either had a lung infection or malignancy, and she was brought to theatre so we can do a pleural biopsy and do on the pericardial and drain the pericardial effusion for her. If she needed to do pleurodesis or decortication. I stuck in a transesophageal echo, as you do for this patient, just to actually see how big the pericardial effusion is. It wasn't very big, but I discovered this area of infarction. So this was a complete misdiagnosis of this patient. So instead of having infection or some malignancy, what the punch in the back was actually an MI that she had here in the septal area. So you can and you can see the infarction in the infarcted area. So what do we do perioperative to actually evaluate patients? I'm going to go through this. I'm not going to discuss this. This is all from the guidelines. We can mostly look at the negative things. Obviously, for what do we ask is firstly, do we do ECGs on all these patients? And we say, yes, in routine operating testing for 12 ECG is of no benefit. And we can see mostly what our level of evidence is there. So you only do this in patients where you've got known disease, or you are very suspicious and you're very worried about them, or where they have arrhythmia, and you have to have identify the arrhythmia. If you want to assess the left ventricular function, then it's basically the same. If it's not, you don't do routine left assessment of the left ventricular function on every patient, only on patients where it's indicated to do it. The same with exercise stress testing. If you've got a patient that you can see here, if they've got excellent functional capacity, then you don't do the tests on them. And because of the routine screening has not been shown anywhere to be of any benefit. If they have symptomatic and you don't know where you stand with them, you don't want to fly in the dark, you do your exercise stress testing. Pharmacological stress testing, as you can see, also not to be done in patients for that routinely. Coronary angiography is also not routinely recommended. If you look at the European Society of Cardiology and the European Society of Anesthesia guidelines, it's much more succinctly summated, and we just say that simply that the ECG is recommended for patients who have risk factors and are scheduled for intermediate or high risk surgery, not even for low risk surgery. And again, routine is not recommended. Stress testing is the same. High risk surgery with more than 2 clinical risk factors and poor functional capacity. So either less than 4 meds, and I would say easily less than 3 meds. We'll come back to that a little later. but as routinely not recommended. Just to come back to the whole concept of METs, the metabolic equivalence, or the VO2 max that we talk about, that we can see 1 to 4 METs is standard light home activities and walk around the house. I'd say that anything from 4 and above is really not in the high risk area. I'd say anything with with any patient who have got a METs value of 3 and below, or 10 mole per kilo per minute VO2 max, these are patients that we have to be very careful for when we do anything more than minor surgery on. And these are just a reflection of what exercises fits into every category. Just the recommendations on preoperative coronary angiography, and just as we said, the guidelines are different from the American Association and the American Heart Association versus the European Society of Cardiology. So you can just see that, but just indications for revascularization. When are you going to revascularize a patient before you do surgery? Firstly, is when there's left main stem disease. These are the big widowmaker, which kills a lot of patients and gives you very little chance for getting out of the case. Then secondly, if 3-vessel coronary artery disease with left ventricular dysfunction, if it's all 3 of the vessels and the left ventricle is not functioning well. If you've got a left main equivalent, with other words, both the circumflex and the anterior descending are blocked and are severely blocked. And then intractable coronary ischemia despite maximal medical therapy. If the patient just have got worsening angina, you have to revascularize before presenting the patient for any surgery. And on this does not necessarily reduce your risk, because in fact, the average patient that dies because of a myocardial infarction only has 38% blockage in that vessels that you are blocking, that causes the heart, the death. Then just the approach to medication. As you can see here, beta blockers. Let's look at beta blockers, and beta blocker therapy should not be started on the day of surgery. That's important. You don't start anything. If a patient has been on beta blockers, they stay on beta blockers. If you want to start them, you can start them a while pre-operatively, but there's no indications to give patients beta blockers, and it makes no difference. In fact, the outcomes are worse if you give them beta blockers on the day of surgery. Recommendations on statins is basically almost the opposite. The outcomes is better both pre and post-operatively to giving them statins. You can start statins just pre-operatively and continue with them post-operatively. It's one of the few drugs that actually makes a difference on outcomes. Antiplatelet therapy, when patients are on antiplatelet therapy, you can see more or less all the antiplatelet agents has to be stopped for about a week. I think it's almost safe to say, if you can't remember specifically, stop it for a week before. And then definitely the intravenous, you've got to stop around about 6 hours before the operations. Other type of anticoagulants that you've got to be careful and can't be trusted are the factor 10A inhibitors. Be careful for them. They need to be stopped much longer before operations than actually the literature actually says at the moment. So anesthesia for patients with ischemic heart disease. It's just a simple thing. Our previous speakers have alluded to this all the time. You've got to avoid myocardial ischemia, and you're looking at this oxygen supply demand balance. So just remove and avoid all factors that increase oxygen demand and impair oxygen delivery. So avoid the increases in oxygen demand. Keep the patient's heart rate calm in between 50 and 70. Don't put any pressure, don't get the blood pressure up, don't increase the afterload, and try not to increase the myocardial contractility by any drugs or anything that you give. And avoid any decreases of myocardial oxygen supply. This is all common sense. You don't have to worry about that, but because you've got to avoid anemia, hypoxemia, and coronary artery spasm, things like that. Avoid your tachycardia. It boils down to avoid tachycardia and extremes of blood pressure. And we're coming back to some other little factors that play a role. How do you do this? Pre-medication, as we saw, and especially Snigdha talked about it in detail. Anything can do. Just keep your patient calm and keep their blood pressure relatively low. You can use any of the anxiolytica. You can use opioids and morphine if you don't have anything better than that. And you continue the medications that are on to the day of surgery, your beta blockers, your calcium channel blockers, and your antiarrhythmic agents, including digitoxin. Alpha-2 and agonists to give it before as a class 3, and you can see it shows no benefit. So ACE inhibitors, you can continue up to the day of surgery and start as soon post-operatively as you can. Monitoring during anesthesia is quite important. This has been extensively discussed by Pompa, so I'm not going to go into this so much. It's just here we have to look a little bit deeper at ischemia, and so at the ST segments, so preferably had at least 2 leads. Lead 2 V4 can detect 80% of ischemic episodes, and adding V5 may increase up to 97% of the episodes that you can see. Preferably invasive blood pressure. If you can have invasive, please go for invasive blood pressure so you get beat to beat. This can onset very, very quickly. CVP catheters, if they've got major blood loss and large fluid shifts, do your CVPs. Pulmonary artery catheters is usually not indicated unless the patients require cardiac output monitoring, for instance, the patients with cardiomyopathies. TOE, transesophageal echocardiography, though not proven, high-risk patients may benefit as TOE may help detect ischemia and ventricular dysfunction, especially diastolic dysfunction. Diastolic dysfunction is the thing that shows up before your troponins go up, before your ST segments go up. You can get your left ventricular end diastolic pressure will go up. It's the first sign of ischemia. Then depth of anesthesia monitoring, and despite the fact that this might seem superfluous, is very important. As we'll see later, that having your patient too deep have got a much higher incidence of ischemic heart disease and of ischemia, and a bad outcome for that. As I'm probably going to, come back and just show you this study that showed that the decreases of more than 20% in mean arterial pressure or mean arterial pressure values less than 60 for a cumulative duration of more than 30 minutes, and deep anesthesia with the bispectral index scale values of less than 45 was associated with an increased risk of post-operative complications in patients. So this is something that you have to monitor throughout, which is actually beneficial to the patient. For induction agents, you can use whatever you want as long as you use it carefully and as little and slowly. Etomidate is preferred, but it inhibits cortisol synthesis, so it's getting very unpopular. Propofol is an alternative, and if used carefully, is excellent. Try and avoid ketamine in ischemic heart disease specific because of the sympathetic stimulation. Intubation, just avoid the stress. Use opioids, lidocaine, or use your induction agents carefully so you can attenuate the hemodynamic response. As I said, with maintenance, there's a lot of studies comparing volatiles with TIVA. There's no real statistical difference proven, and you can use any of these. You know, the only thing that stands out in the literature maybe is sevoflurane at the moment. But the rest, all of them are good to use. It's how you use it, not what you use. Then with extubation on non-cardiac surgery, just do it smoothly. Avoid sympathetic stimulation. You can achieve this by using opioids, you know, your Remy fentanyl infusion, and your beta blockers in patients. Neuroaxial techniques, I've just given you a lot of referrals here, references here, because it can, if it's possible to put in neuroaxial block, it does decreases the 0 to the 30-day mortality and your risk of pneumonia. It gives you the sympathetic blockade. It does the same thing to the coronary vessels that it does to the peripheral vessels. It dilates them and you've got more flow. So neuroaxial techniques and regional techniques are very good for your cardiac patients, if your ischemic patients. So please go ahead and use them as much as possible. Obviously, neuroaxial techniques are not always possible because of anticoagulations of some of these patients and dual platelet therapy and things like that. So it's dependent on the procedure. Then what happens if you do get a patient and you've got to treat the ischemia? You've got to, the factors which alter myocardial oxygen supply and demand balance should be treated. So you just see that you can correct your demand and your balance. So you avoid your tachycardia and your hypertension, and just, avoid pain or deepen your anesthesia or use your blocks. You can use beta blockers, esmolol, metoprolol, and labetalol are useful. If the ST segment changes still exist, you can give vasodilators like nitroglycerin. Hypertension can be treated by fluid and vasopressors, phenylephrine. Persistent hypertension can be treated by vasopressor infusion, inotropes, and intra-aortic balloon pump if you need to be. You should keep your hemoglobin at more than 8 grams per deciliter, or 80 depends on milligrams. And you have to treat your hypothermia as it comes along. Just watch out for your temperature as well. Just another case, just to show you here, was a 68-year-old lady for a malignant mesothelioma. Unfortunately, I do only cardiac and thoracic anesthesia, so my non-cardiac anesthesia are all basic thoracic anesthesia. This lady was very, performance status 0, so she's a very fit lady. She's on no medication, non-smoker, but she had a mesothelioma, and she was for EPD, where major surgery, extrapleural, extended pleurectomy and decortication. At the beginning, you can see here, everything is nice, hunky-dory, blood pressure is nice and low, heart rate's a little bit up. She continuously had quite a high heart rate, starting heart rate of 104. And then she became ischemic. As you can see, the STs went up. And what's another thing in the monitor is to look at ST segment, just add some computerized ST segment analysis, and you can see the STs went down. And all I did for her is specifically, I topped up the epidural and gave her a fluid bolus. Blood pressure came down and the ST segments came back to normal, and she had a good outcome, and post-operatively we had no problems with her whatsoever. So what do you do if you get these arrhythmias? And this is, well, cardiac surgery, but that's just to show you how a fibrillating heart looks and how ineffective it is. The quickest thing for this is immediately to defibrillate the heart. You can use intermediate intravenous amiodarone, and it's always good to start the amiodarone and do your defibrillation and then carry on, because you don't want any further incidents afterwards. Magnesium sulfates can be considered with Torsades-de-Pont and long QT syndromes. And you can see beta blockers in combination with magnesium sulfate for Torsades and sinus bradycardia. And you can speed the heart up with isoproterenol if you want to, if you could pause-dependent Torsades or long QT syndromes. And you can also use some calcium channel blockers should patients have a wide complex tachycardia of unknown origin, that you can use that. So you treat everything as you go along and as quick and as early as possible. AF is the most common arrhythmia that we find, and you can stop them vagal maneuvers, push on the carotid or on the eyeballs, or give them beta blockers or calcium channel blockers as you go. I use amiodarone very, very early on these patients, especially to get rate control. And you get 3% new onset atrial fibrillation or flutter with a 1.5% stroke rate within 1 year. So you have to treat this quite aggressively. The bradyarrhythmias usually respond well to short-term pharmacological therapy, glycopyrrolate or atropine, and you rarely need temporary cardiac pacing. But if you've got a complete block or something, just get the cardiologist to put in temporary pacing wires as quick as possible, just to get this heart and to look after this heart. This is just a patient that we didn't look very well after his this arrhythmia, and the echo pictures doesn't really correlate with the ECGs that you have. This is a patient that was anticoagulated, so no possible neuroaxial blocks could be done on him. He had a previous TAVI, as you can see, a TAVI valve in place there, and he had a CABG 8 years before this, and he was here for emergency abdominal hernia repair with strangulated hernia. He went into a VTAC and then was cardioverted, and this is how he came out of the cardioversion, and the heart was very, very badly stunned. And this is how a heart looks when you do CPR on it. And eventually we got this patient resuscitated and got him out of theatre. Just the post-operative management is important, and we'll be getting to finish in a few minutes' time. The difference in outcomes is a difference between hospitals in terms of post-operative mortality are not due to the incidence of complications, but the way in which they are managed. And so you've got to pick them up early. And for post-operative ischemia, the MIs take place within the first 24 hours most of the time, the fatal MIs or the bad outcome MIs. And the best is to look at the troponin levels, and you can troponin and also BNP levels gives you a very, very good oversight of what happens to these patients. I'm not going to go into this detail because you can read all about this in here in these references, and because that is very sensitive. So if you've got any doubt of whether a patient has got any ischemia or any infarction post-operative, do their troponin and see what is going on. If it goes up, the patient has had a heart attack, and because these heart attacks or ischemic events post-operatively are usually masked by the pain, the post-operative analgesia, and the ECG changes are really rare. So again, you have to look at, if you don't have echo information, it's better to look at the troponin levels. And if you've got any troponin, you've got to act on them very quickly. So just a summary of what I've said. It's not rocket science, it's absolutely common sense. If a patient looks sick, they are sick. They're old, sicker, immobile patients are high risk. Failing ischemic stress hearts, high risk. Bigger, longer, complex operations, high risk. Anesthesia, high risk anesthesia. You do it like you're driving on a wet road. You do everything slow and deliberate, and you don't upset anything. Always expect the unexpected. You have to be vigilant. You watch your trends on your monitors. The trends are much more important than anything else. You've got to prepare properly. As Snigdha has also said, you've got to monitor and keep on monitoring your patients post-operatively with high suspicion. You've got to treat each complication early and with maximum input. Don't think I'll do something later or we'll see what happens. When it happens, treat it quickly and use all your resources available. So I thank you very much from Greenfield Hospital. Thank you.
Thank you, Dr. Johan Benz, for a wonderful talk on and comprehensive talk on this topic. And you are really stressed about the importance of post-operative troponin monitoring, which very few people do, because peri-operatively also we have to take into consideration. And this is a very important take-home message you have given, that one has to also monitor the patient post-operatively. Intraoperatively, all the guidelines related things you have made it very clear and simpler by your lucid talk, and we thank you very much for that.
Thank you, Dr. John, for the excellent coverage of this difficult topic. I think we now move on to the next talk.
Yes, sir. Thank you, Dr. John, for such an elaborate discussion and for such illustrative videos and teaching the basic elementary things we need to do. Thank you for accepting our invitation and sparing time on Saturday afternoon especially. We would like to felicitate Dr. John with an e-memento. Please accept the memento as a token of our gratitude, sir. So now moving ahead to the last talk of today's webinar. So now moving to the last talk of today's webinar, and for the same, I would like to invite Dr. Sameer Khanna. Dr. Sameer has done his Bachelor of Medicine and Bachelor of Medicine and Surgery, FRCA, FCA, EDIC, FFICM, NBE, and MSc. He is the consultant in anesthesia and ICM, Glenville Hospital, providing elective and emergency care to ECMO and wide range of medical and surgical patients. He has vast teaching and research experience. He is the local investigator in the following NIHR and European studies: popular, retrospective use of zanamivir in H1N1, SNAP1, and Optimize. He is author in multiple publications in major anesthesia and intensive care medicine journal. He is the head of service in charge of Glenville ICM, managing major mixed cardiac and general intensive care unit. Welcome, sir. Dr. Sameer will be talking about anesthetic management, pregnancy and valvular heart disease, its anesthetic management. Risk comes for not knowing what you are doing. Valvular heart disease is a common cause of cardiovascular disease that affects women of childbearing age. During our practice, we come across so many pregnant patients with valvular heart disease, and as it is rightly said, risk comes for not knowing what you are doing. Having knowledge and correct application of that knowledge is very important while managing such cases. And to add to the sea of our knowledge, we have Dr. Sameer Khanna. We welcome you, sir. I request Dr. Sarita ma'am to please start the presentation. Ma'am, are you able to share the screen or should we start it from here? Ma'am, unmute yourself.
Hi.
Can you share the screen?
होत नाही का?
नहीं होते हैं शेयर स्क्रीन दाखवत आहे जस्ट अ मिनिट. तिकडनं शेअर कर. डॉक्टर प्रियंका.
Yes, ma'am.
हाँ तिकडनं शेअर कर, इकडनं शेअरिंग होत नाही आहे.
Okay, ma'am.
Yeah.
I would like to start my presentation by a quote from a famous professor by the name James Cars. Said, "To be prepared against surprise is to be trained, to be prepared for surprise is to be educated." I'm Sam, one of the consultants from Glenfield Hospital. Today, I'll share with you our experience of managing heart disease and pregnancy. Heart disease is the biggest killer of pregnant women in the developed world. It's also the main indirect cause of death in countries with established basic maternity infrastructure. NICU publishes training report called Embrace UK. These reports look into lessons from audits and confidential inquiries of maternal deaths. The diagram below is from the most recent Embrace report published in November 21, including figures for the period of 2017-2019. You can all clearly notice that maternal death is mainly from cardiac causes. The main pathologies for cardiac deaths in the UK is ischemic heart disease, heart failure, and sudden arrhythmia, which is a shift from the valve heart disease. This is related mainly to the change in the natural history of mitral valve disease in the UK.
Voice is not audible.
आणि व्हिडिओ स्टॉप होते हैं.
The maternal mortality rate in India for the period 2016 to 2018 was associated with 2,500 additional mothers saved annually. I found conflicting reports, but it's estimated that up to 50% of maternal deaths are contributed to indirect causes. Heart disease in India is also the main indirect cause of maternal death. So why heart disease is such an issue during pregnancy? In order to understand the significance of pregnancy and labor on heart disease, it's really important to understand the physiological changes associated with pregnancy. Most of these changes usually materialize during the second trimester, and while some of these changes will have little or no impact on the regurgitant valve heart, their impact on stenotic heart valve conditions is quite detrimental, associated with significant impairment to coronary blood flow and a mismatch between the oxygen demand and cardiac output. This mismatch is secondary to the inability of the heart to adapt to the increased demands. It's what we call the fixed cardiac output system. It's crucial to understand these basic concepts in order to plan and oversee a safe delivery. In this chart, you can notice the different hemodynamic changes associated with pregnancy. Most of these changes peak at the beginning of the second trimester between week 16 and 20. Unfortunately, a very important aspect of managing these conditions outside the anesthetist's control. It's really important to make an early diagnosis of unknown valve diseases. If symptoms of shortness of breath are contributed to pregnancy and the diagnosis of valve disease is delayed, this is associated with high mortality. So let's start with the easy group of pregnant women with an already known valve heart disease. In this group of women, proper counseling and expert opinion is crucial to optimize good outcomes. The most recent Embrace report was very reassuring that all cardiac maternal deaths were related to undiagnosed cardiac conditions preconceptions. None of the maternal deaths were in women with known cardiac conditions, which is very reassuring. Known cases will allow proper risk assessment of the valve condition and preconception optimization, including surgery if indicated. In the UK, preconception counselling is usually the case in known cases of bicuspid aortic valve. It is important to understand that majority of mitral valve disease present during pregnancy due to their soft clinical features. Known heart valve conditions, the modified WHO scale is a validated scoring system. This has been validated only for women with isolated valve disease and normal ventricular function. The risk is higher if the women suffer from other conditions like diabetes, obesity, and others, and it will be added in nature. Also, for patients with mixed valve disease, like mixed mitral disease, the risk is usually additive, although there is little if no evidence in the literature on how to calculate the risk in these conditions. The scale is made up of 4 different grades. The higher the scale, the more the risk. For women with scale 1, they carry similar pregnancy risk to the normal population, while in women with scale 4, pregnancy is contraindicated. This study from a tertiary center in South India confirms the WHO scale applies to the Indian population. Total of 681 women with rheumatic heart disease were included. 26% were diagnosed during pregnancy. Composite deferred cardiac outcome during pregnancy and postpartum occurred in 122, 15% of the pregnancies, with 12 of them succumbed to the disease. In multivariate analysis, predictors of composite deferred cardiac events are severe mitral stenosis with an odds ratio of 7.7 and pulmonary hypertension with an odds ratio of 6.9. The outcomes are for a population presenting to a tertiary center and might not be a true reflection of the general wide population. This table demonstrates how the risk depends on the maternal heart condition. Pregnancy is contraindicated to severe mitral stenosis and severe to critical aortic stenosis. This also confirms the outcome of the study by Jyoti Bagel et al., where the odds ratio of severe complications and death was 7.7 for severe mitral stenosis. It is vital to have thorough history and clinical examination to identify these conditions. It's also the ability of the cardiologist. Important pillars in the risk assessment. Finally, the balance between risk to the mother and the fetus from medication. Finally, the balance between
Mute Saleh.
or mitral replacements for severe regurgitation is a complex decision and should take into account the severity of the left ventricular dilatation and the functional impairment. Severe aortic or mitral regurgitation can be classified as WHO-3. In pulmonary regurgitation, the main focus in women with the disease is other second associated condition and right ventricular size and function. Take great consideration if this is a secondary to previous sculpt repair, as isolated pulmonary incompetencies is unusual. Very rarely interventions are needed, only in situation where the RV starts to struggle and possible early reduction of labor at week 36. Obviously, sequential echoes are important to monitor the situation of the right ventricle. In patients with primary tricuspid regurg, pregnancy is usually tolerated well. This includes conditions like Epstein anomaly, while secondary tricuspid regurg is usually a reflection of dilated or severe right ventricular impairment. Hence not tolerated very well, and they can be classified into WHO scale 3 to 4. It's uncommon condition, and currently in Glenfield we have one case for tricuspid valve repair. She suffers from severe tricuspid regurgitation due to insertion of pacing wires. And unfortunately, she lost pregnancy during the severe tricuspid regurgitation previously. Now we'll talk about the stenotic valve condition, which is really the serious business, even to the anesthetist with the experience. Mitral stenosis, this is exactly the hemodynamic situation that you don't want to be in. So you need to be careful in monitoring and identifying these situations quite early. Balloon valvuloplasty plays a major role in managing this group of patients. Don't assume they will survive labor without proper planning and decisions about their management throughout their pregnancy. The timing of intervention depends on the mother's clinical state and the likelihood of later decompensation. The gestational stage should also be taken into consideration. So at 19 weeks, usually the fetus is beyond the most radiation sensitive first trimester, and the uterus still below the level of the umbilicus, so radiation exposure is less than later in pregnancy. If the procedure is done after 20 weeks, gestational obstetrician must be present to enter the uterus in the unlikely event of cardiac arrest in order to allow effective maternal resuscitation. If mitral valvuloplasty is done after 24 weeks gestation, a full obstetric and neonatal team must be present, since maternal cardiac decompensation or arrest would necessitate emergency cesarean section delivery of a viable neonate. It's important to remember that mitral stenosis symptoms can be very subtle and early diagnosis save lives. In the UK, there is significant shift in the typical age of presentation, maybe due to the slow progress of rheumatic mitral stenosis. Hence, the shift in cardiac maternal mortality etiology from heart valve conditions to heart failure and arrhythmia. These ladies in the UK usually present now in their 40s, 50s instead of their 20s, and usually the disease progression will take 10 to 20 years for symptoms to develop into a severe condition. Understanding the pathophysiology of this condition is very important for the ability of the anesthetist to manage. So the increased stroke volume and the tachycardia of pregnancy compared with the impaired diastolic flow through the stenotic valve will cause the increased left atrial and pulmonary venous pressure significantly. This will reduce your cardiac output and will impair coronary perfusion and myocardial oxygen supply. If, for example, atrial fibrillation develops, the loss of atrial transport and the increase of the heart rate can precipitate pulmonary edema and cardiovascular collapse. Also, this can have a significant back effect on the right ventricle. This can be associated with a quite significant increase in the right ventricular and diastolic pressure and right ventricular and diastolic volume. This is secondary to the pulmonary hypertension and can be associated with quite significant tricuspid regurgitation in chronic conditions and severe disease. This will cause the recurrent fluid transitate into the lung, which reduces the lung compliance and increases the work of breathing, causing large fluid shifts, head down position or uterine contraction to even raise the pulmonary pressures further, which can be associated with quite significant decompensation. The basic physiology and physics laws for mitral valves follow the Gorman formula, as this governs the flow across the mitral valve and increase in the cardiac output in pregnancy and decreased diastolic time if AF develop will not be tolerated very well, which you can see obviously from the formula here in this slide. The Gorman formula very clearly actually demonstrates the mismatch between mitral stenosis and pregnancy. Mitral stenosis severity is an echo-diagnosis, and these are some of the figures that will help you identify severe mitral stenosis. In my practice, I find the mean pressure gradient of 10 and above associated with significant mitral disease. Finally, it's really important to identify the etiology, and while the majority of cases are rheumatic valve disease, it's very important to identify other rare conditions like parachute mitral disease. These conditions usually are non-amenable to balloon interventions, and surgery is required prior to pregnancy or following an abortion procedure. Next few slides will talk about aortic stenosis, which is usually tolerated well during pregnancy and labor. In borderline cases, exercise echo can help to identify high-risk pregnancy, as it can clearly demonstrate the ability of the body physiology to adapt to the stresses and changing cardiac output requirements. In severe aortic stenosis, there is significant mismatch between the diastolic pressure and the coronary perfusion pressure, which we can see from the formula below. So what you expect in pregnancy, especially with the peripheral vasodilatation of the venous and arterial system, there will be a drop in the aortic diastolic pressure, while at the same time there will be an increase in the left ventricular and diastolic pressure. This mismatch is exacerbated due to the physiological changes of pregnancy, hence. In conditions with critical aortic stenosis, there might be a sudden and severe decompensation due to the poor perfusion of the left ventricle. This will usually be noticed by ventricular arrhythmias, which will be complicated into ventricular fibrillation and cardiac arrest. This diagram here demonstrates the pressure changes across the left ventricle and the coronary arteries. And as you can see, that the flow will be different across different stages of the cardiac cycle. This flow is different depending on the coronary artery, so the left coronary artery will have a significantly more impact than the right coronary artery, which will have a degree of flow throughout the cardiac cycle. There is also an increase in the work of the left ventricle to sustain cardiac output due to the pressure gradient, with with the aortic stenosis. So the gradient can be measured with echo, and a gradient of 40 and above mean pressure gradient is associated with significant aortic stenosis. It's crucial to measure the pressure gradient, as it's quite important to subclassify and estimate the risks associated with different categories of aortic stenosis. My personal threshold for specific strategies and treatments depends on the subgroup of aortic stenosis. So I'm more concerned about types of aortic stenosis associated with low pressure gradient, as this usually affects impaired left ventricular systolic function or severe left ventricular hypertrophy, which can be associated with high mortality and significantly can offer more challenges in hemodynamic situation associated with significant volume shifts. So these type of patients will be very challenging, as they will not tolerate any kind of bleeding or any kind of extra fluid not managed very carefully. Following the discussion about the different type of valve condition, in my opinion, I think the most important predictor of outcome in all these conditions is the availability of specialist team with expertise in managing these cases. This will provide the ability to have an MDT discussion and plan the pregnancy and delivery in as safe as possible way. The MDT team should include cardiologists, cardiac surgeon, obstetrician, cardiac anesthetist, and intensivist. In Glenfield, when we have these cases, we also invite one of our obstetric anesthetists to be part of the team and have an input into the delivery of these patients. They will bring experience, skill in managing regional anesthesia and other aspects of labor-related anesthetic issues. Now that we've done most of the hard work, and you're lucky that this woman have been counseled properly and optimized by the specialist pre-labor, that doesn't always happen. And we know about 25% of women, if not more, present to labor with previously undiagnosed valve condition. Normal vaginal delivery is always the preferable mode of delivery and should be persuaded if possible. This normal vaginal delivery still should be managed in a specialist center where monitoring is staff with the appropriate skills to manage these valve conditions are actively involved in the delivery process. Early analgesia and other anesthetic managements, including epidurals, should be encouraged and should be standards of care in this group of patients. I always use invasive monitoring, large IV access. In the extreme cases, I recommend central venous catheter and consider insertion of a PA catheter sheath in case you need to resuscitate, or even for a pulmonary arch catheter flotation post-delivery. Always involve the ECMO colleagues in the decision where to insert your central lines in case the patient deteriorates and is ECMO candidate, as the availability of ECMO as a rescue therapy is quite advantageous in this group of patients. You also need to have a TOE available to hand and use when you can. We also have a wide range of different transthoracic ECMO machines which we can use for this group of patients. In addition to invasive line monitoring, cardiac output monitoring is a good idea, where you have to be aware of the pros and cons of different cardiac output monitors. In our center, we usually use echo to calculate cardiac outputs, and in severe cases, I would usually insert the pulmonary arch catheter and use it for cardiac output measurements if needed. The role of regional anesthesia in this group of patients is very important. It is beneficial an insertion of an early epidural and gradual titration of analgesia to effect. This will be tolerated well if used with close monitoring in the right environment and will tip the risk-benefit balance by reducing the sympathetic effects of labor. I personally don't insert spinals in this group of patients, so I have good experience with CSEs, and very small dose of spinal CSE might help to block the sacral branches to assist in normal vaginal delivery or with instrumental delivery. And in the small number of cases that in need of general anesthesia is there, I usually use high-dose opioids and benzodiazepines in almost all my cardiac cases. While this is not exotic enough to some anesthetists, it does offer hemodynamic stability. It is important to bear in mind the risk of these drugs to the fetus and need to inform the neonatology team as the baby may need resuscitation and some support immediately post-delivery. Using accommodate is another option, and there is very little evidence to support one option over the other in terms of safety and hemodynamic stability. So finally, my summary point for this session is severe mitral stenosis, still a significant killer of women in labor. Cardiac risk in the UK shifting from mitral valve disease to heart failure. Many conditions will tolerate pregnancy and labor well. Do not expect severe mitral stenosis to be one of these. Without proper planning, these patients are the highest risk and they potentially will not survive labor. Management of pregnancy and labor should be in a specialist center with available expertise to manage this group of women. Thank you for listening. I'm happy to take any questions.
Thank you, Dr. Samir, for this excellent presentation, coverage of a very difficult talk, difficult subject, difficult in the sense because it is many cardiac anesthetists don't really get to do obstetric work, and vice versa. I mean, obstetric people do come across these patients, but then they may or may not have the requisite experience for handling such difficult ones. So I think it's good to know about the basic fundamentals of pregnancy as well as the fundamentals of heart disease and manage these patients accordingly. I thank you for your extensive coverage of this talk, and I'm just trying to see if there are any questions in this. The meanwhile, I will just, do we have him online, Dr. Samir?
Yes, I'm here. Thank you for having me as part of your group today. It was a lovely day.
Yeah, Dr. Samir, my question for you would be, was to like, as to what I said, like in terms of experience of cardiac anesthetists not having obstetric one and the general obstetric anesthetist not having enough cardiac experience, how would you kind of gel these things together to manage a difficult obstetric cardiac patient?
It is quite unusual in the UK, to be honest. We are more shifting into dealing with congenital heart disease and heart failure. But these cases in the UK, they get screened so extensively. So we always share that experience. We usually get emails which we share across the department. So a large group of anesthetists become aware of how people think about planning this type of delivery.
Right.
And as I mentioned in my presentation as well, we usually try and involve some of our obstetric anesthetists in the delivery of these cases. So that kind of, not just for their support and professional experience, but it's also to share the experience in managing these patients together.
Okay, there was one more small question regarding, you mentioned something about having exercise echo in aortic stenosis. I just wanted to know whether it is actual exercise echo or is it some kind of pharmacological stress echo?
It depends on the cardiologist's assessment, but you're correct. It's more kind of a pharmacological stress echo rather than an exercise echo. And as these cases are diagnosed the majority of it actually happened with preconception counseling. So when the couple start to think about the need for valve surgery, precedes the conception or not.
Oh, okay. Okay.
Dr. Samir, my question is, which is the ideal time for doing a balloon mitral valvotomy in case the patient is finding it difficult to continue the pregnancy due to congestive heart failure? In a mitral stenosis case.
Yes, sorry. So yeah, so the the balloon valvoplasty is a quite complex decision, and that's why I said you need to manage these group of patients in a specialist center where there will be a follow-up and screening to identify the exact time, because you have to balance the risk, because despite it's a small risk, there is a risk that the pregnancy might be lost at that point. So I think most people would think around week 19, 20 would be the ideal balance between the risk to the mother and the fetus, really.
Do you recommend any in situ endocarditis prophylaxis during the cesarean section of these patients?
No, for the majority of UK patients, we don't recommend prophylactic treatment, really. Possibly if the delivery is instrumental, I think that might be an indication for antibiotic, because that's where you're going to have a high risk. We do give prophylactic antibiotic for the cesarean sections, but I think going through the labor canal is potentially more risk if you're going to use instrumentation and cutting and all that stuff.
We have come across, mostly we try to avoid the uterotonic drugs during the cesarean, but sometimes we may come across a situation where there can be a uterine relaxation. So how do you manage such situation? Because if you try to give uterotonic drugs, then the patient may have a risk of going into pulmonary edema. But if you don't give it, then patient has a risk of bleeding from postpartum hemorrhage.
I think the way to do it is just to be more gentle and monitor closely. So sometimes you might consider running an infusion of centometrin, and I would rarely recommend ergometrin, really, maybe more centometrin, but going as a slower infusion, maybe a smaller doses, and reassess. We usually have a quite experienced senior obstetrician in these cases, so they will have a regular assessment and make sure that the uterus is contracting. So it's an ongoing professional discussion about which risk is more, because the other problem with this group of patients, in my opinion, I think the safest time is during labor, because you will have like 5 different consultants from different specialties. The problem happen at night when they start to bleed or have all the other issues, and then you can't have they can't tolerate the hemodynamic instability. So you have to balance that risk somehow.
Any question for Dr. Benz about the coronary disease? For my question to Dr. Benz regarding the patient who have undergone coronary artery intervention in the form of either CABG or stenting, and they have been stable, say, last from 7 to 8 years. Now, these patients, when they are presented for a non-cardiac surgery, how much we should evaluate them, just to take into consideration the functional capacity, or we have to do a more extensive investigation so that we come to know whether there is stenosis or advanced mental disease, or the there are blocks into the grafts of the CABG patients?
Yeah, no, it's a very good question, because the thing is with them is you again go firstly back to the history. What are they functional? How are they functioning? If they are functioning well, and if they've got no symptoms, they required no escalation of treatment, then I think if it's either intermediate or low risk operations, you can go ahead without any further investigation of them. If you have any doubt, if they've had either unstable angina or periods of congestive heart failure, or they have fallen below 4, that 4 MET group, or VO2 max of below 10, then yes, I'd say they are candidates to do repeat coronary angiography on them, or just at the moment you can just do some CT scan, flow CT scans on them as well, and have a look and investigate according to their symptoms and the clinical picture that they have.
CT scan means CT angio?
Say again?
CT angiography?
Yes.
Okay.
SK, there's a question for Dr. Johan from Yatharaj Bharadwaj. What dose of magnesium sulfate should be generally used for the prolonged QT syndromes?
it's basically normal. If you've got children is 40 milligram per kilo over 20 minutes infusion. Adults, I'd say, in an adult, probably 1.2 to 2 gram over 20 minutes. And then you can repeat after 15 minutes. So that's the basic dosage that you start off. If it's a big adult, I'd start off with 2 grams.
Thank you.
Yeah. My question is to Dr. Benz again. We are looking after the ischemic preconditioning in a ischemic heart disease patient undergoing cardiac surgery. Do you have to take the same precautions while giving anesthesia to the non-cardiac patients?
Yeah, I think with ischemic preconditioning and all of this, you lower, obviously, you get a very good idea of where you stand with the patient, number one. And number two, you lower the risk of the second ischemic event as such. But I think you should work these patients up according to the same data as well. Firstly, look at the historical risk factors in the history. Then secondly, at the clinical picture of the patient, which risk group he falls in the clinical picture. And then thirdly, again, look at the risk of the operation that you're going to do on the patients. And then optimize the patients. But people forget often with these patients is we put all patients under one umbrella and say everybody has got the same blood volumes. What we don't look at is, for instance, patients with coronary artery bypass graft, as well as patients with tight aortic stenosis, only have blood volumes of 45 mils per kilo, compared to a patient with mitral regurg that can have a blood volume of 80 mils per kilo. And if you fall behind with these patients, or you suddenly dilate them quickly, then they will become ischemic, and then nothing that you've done before will help. So your intraoperative, your preoperative and intraoperative approach should be the same, whether it's for cardiac or for non-cardiac surgery.
Thank you.
A couple of questions for Dr. Samir, I suppose. One question by Dr. Yatharth is, do you use any opioids prior to induction of mitral stenosis patient?
Yeah,
okay,
so
that's the already answer.
I rarely use pre-meds these days, but I always discuss with the patient. So the concern with this group of patients, it depends how long is the delivery going to take place. So if you have a clear plan and you're going for cesarean section, it might be slightly different. So just you have to a little bit balance the risk and the benefit and discuss with the patient. But I don't use opioids as a standard. I just use a high dose of fentanyl for induction rather than giving pre-meds.
Okay, and there is a query on how effective is intramyometrial carboprost and methyl ergometrin?
Yeah, that's another option. I don't know the exact efficiency of that, to be honest, and how it compares to the symptometrin and the standard ones, but it's not our first line of treatment. But it's something available for our obstetrician to use in the severe cases.
Okay, thanks. Dr. John Duhan Benz, I had a question for you. What is your experience with this ACS risk calculator, this NSQIP? Do you use it routinely in your practice?
Can you just repeat again? I've got just a bit of a sound problem.
The ACS risk calculator. Do you have anything of that thing to help you in your day-to-day practice? The risk calculator.
There's obviously several risk calculators. My experience with the risk calculator and the risk indexes is to use the simplest ones that you can use. But it's good to use one that, the best one that you have access to. So I would use anybody, if they have got any doubt of what the patient's risks are, to use a risk calculator, calculate the risk, and then this electronic one, these electronics ones are lovely. You can just sit and you tick the boxes, and it throws the risk out for you in the end. So that they are really useful, especially if you you in some gray areas with the patient and you don't know to say yes or no. If you're a non-cardiac anesthetist, then I would definitely advise people to use them.
Yeah, thank you very much.
I think we had an excellent discussion on both these.
SK sir, you are mute. Please unmute yourself.
I thank both the speakers for really making both the topics so difficult and very simple in their own style, and very nice presentation, very good slides, and very good discussion thereafter. I think these topics are evergreen topics in my opinion. So many conferences we have been listening to this, but still on this Saturday evening, so many people are attending this webinar. Speaks about the speakers and the topics. So we thank the organizers for organizing and selecting these topics for today's webinar. We thank you for inviting me and Dr. Vinay Kulkarni for the webinar. Thank you.
Yeah, it was an excellent session. Dr. Snigdha and everyone who has joined. It was really a very informative session.
Dr. Snigdha and Dr. Pratibha have been working to organize this webinar from more than a month. Yes. And we really congratulate them to get these people from USA, from UK, and from India, and getting it arranged and disturbing the overseas people on Saturday. When there is a well-deserved weekend is there. So we thank you for them. And thank you, Dr. Snigdha and Dr. Pratibha, for such a excellent topics you have selected for today's webinar.
Thanks, XK. I was muted, so I was not speaking. Now I unmuted myself. Thank you very much.
Thank you so much. Thank you all the speakers. Thank you, Dr. Shlam. And thank you, Johan. Thank you, Samir. Thank you, Pompa, and all the chairpersons. It really was a great pleasure to me to bring everyone together on a same platform, and this is the beauty of the technology we have today. Like, in spite of sitting in 4 different corners of the world, we can see each other, we can share our experiences and knowledge, and thank you for giving me this opportunity. And I'm really feeling very delighted to connect back to my people from Nagpur, from my medical college, and I'm really very happy to see all of you. Thank you so much.
Priyanka waiting for the e-memento for sir.
Yes, ma'am. Thank you, Dr. Samir. You have beautifully consolidated the whole presentation. We would like to felicitate Dr. Samir with e-memento. Please accept it as a token of gratitude, sir. We would also like to felicitate our chairpersons, Dr. SK sir and Dr. Kulkarni sir, with e-mementos. Thank you, sir.
Thank you.
Thank you. Thank you.
Now, moving towards the formal vote of thanks, I request Dr. Sarita Zobrekar ma'am to propose the formal vote of thanks. She is the Honorary Secretary of ISA Nagpur City Branch.
Thank you, Priyanka. I took this opportunity on the Saturday evening and morning and afternoon for overseas people to thank you all for coming for the CME, joining for the CME today. My sincere thanks to our Vice President, ISA National, Dr. Anjali Bude Madam, and a member of Advisory Board of MSCIC for guidance for the CME, and Dr. Saurabh Bade, GC member MSCIC, to join the program. My special thanks to our organizing chairman, Dr. Pratibha Deshmukh Madam, who is the head of the department of the Dattamakhi Medical College and our dynamic ICNCB member, and our guidance to all of us to organize this particular CME today. Today's MMC observer, Dr. Narendra Tamne sir, my special thanks to Tamne sir. extremely thankful to our overseas coordinator, Dr. Snigdha, for her excellent support and immediate communications for uniting us all together on this platform. Special thank to faculties of today's program, Dr. Pompa Kukreja, Dr. Snigdha Akin, Dr. Michael Schlam, Dr. Jahan Pans, and Dr. Samir for joining us today with the different topics with excellent, critical, but a very elite and elaborative presentation. My sincere thanks to chairpersons of today's program, Dr. Sachin Patel and Dr. Jaswant Somal, Dr. S.K. Sir, and Dr. Vinay Sir for giving us the precious time in the Saturday evening. I wish to thank all the senior ISA members and the overseas delegates who have joined from the program today. Special thanks to our Master of Ceremonies for today's program, Dr. Priyanka and Dr. Anjali Borkar. Please accept the mementos from the President ISA NCB, Dr. Priyanka and Dr. Anjali. Special thanks to you. My sincere thanks to our dynamic president, Dr. Kiran Vevade, for motivating us to have the discussion on this program for today. Special thanks to Dr. Nishant, Mr. Nishant from Atlantic for supporting us for the live program, and Mr. Manoj Singhi for having the lovely mementos. And we'll take a leave with a discussion for a nice discussion today. Good evening, good afternoon, and good night to all of you. Thank you, everyone.
Thank you. Thank you, everyone.
Thank you so much.
Thank you. Bye.
Yeah.
Take a leave.
Thank you. Bye.
Yeah.
Bye-bye.
Bye-bye. Thank you.
Thank you very much for the patient hearing and kind attention. I would again like to extend my heartfelt gratitude to ISA Nagpur branch for their help and support in organizing this webinar. Thank you so much. Good evening, good afternoon, good evening, good night, everyone.
Yeah. Bye-bye.
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 Bye.
Bye.
Bye-bye, sir.